Right. So welcome. This is Dr. Philip Kurula here, welcoming all of you to this webinar on manual SICS and secondary IOL implantations. Thank you, everybody, especially Dr. Roshan, Dr. Rajagopal, and Dr. Rajesh.
Yes,
Rajesh, who invited us and who's organizing.
Rohan is
Thank you very
organizing,
much. You've been doing a wonderful job, and thank you very much for this opportunity. You're doing all the work, and we are getting the credit. Thank you very much. And so welcome Dr. Ravindra, Dr. Andreos, Professor Andreos, Dr. Amulya Sahu all the way from Bombay joining us. And we have Dr. Jacob Koshi and Dr. Rohan, of course, Dr. P. Sasikumar, Dr. Ashish Kuruvilla, and thank you very much for joining in. Now, I want to just say a few words about the panelists. After that, I'll request Dr. Andreos to introduce the speakers. And we have Dr. Amulya Sahu from Bombay, founder of International Society for Manual Cataract Surgery. He is famous for his 2mm SICS. He is an unbeatable debater for MSICS, so passionate and such a visionary. And he practices in Mumbai. Thank you very much for joining us. And he's co-chairman. The NST Raju, of course, is not feeling too well, so he's not able to join. Dr. C.V. Andreos from Andrews from Thrissur is a professor of ophthalmology in Jubilee Medical College Hospital. Done a lot of work in anterior segment surgery and including SICS. Then we have on the panel, we have Dr. P. Sasikumar from Palghat Vijaya Eye Clinic. He's one person who is who doesn't want to be in the limelight. We had to literally force him to come and join us. But he is one person who's done a fantastic amount of work in SICS. He is famous for his dropless surgery. That is, he does not dilate. He gives intracameral dilating agent, and also he does under topical anesthesia. And Dr. Andreos, can you please introduce the speakers? After that, we will go on to the first speaker.
Thank you, Philip sir. Can you hear?
yes, sir.
Yes.
Okay. Welcome, Dr. Sahul. So, Amulya Sahu, welcome, sir. Then thank you, Palakkad Ophthalmic Society and KSO. Rohan done a wonderful job. Rohan, Rajesh, and Shashi. I am attending the meeting till morning 9 a.m. onwards. It is going wonderfully. So my job is to introduce the faculties. The chairman is Dr. Philip Kurula. I think this audience, there is no need of introduction to Dr. Philip. He is the senior most cataract surgeon in Kerala or South India. He has his education from CMC Vellore and Ludhiana. Then he has a community service in lot of many years in Punjab. And he has been in Operation Eyesight Universal Eye Hospital at Metupalayam. There are also a lot of community and cataract services. Then after that, he started his clinic at Trivandrum Aradhan Eye Hospital in 2000. Now he's a good practice in Trivandrum. So he's one of the surgeons who started with intracapsular cataract surgery. That time it was, I still remember that is one graft knife and everything. So I also started such a practice in Ahmedabad also. That in North India it is all intracapsular with one graft knife and everything. Then he switched out to extracapsular surgery, then into small incision cataract surgery, manual factor surgery, then into PAPO surgery. Now he is authority to have a 3mm opening with the cataract surgery with a four-level lens or toric lens or astigmatism. Everything is doing fantastic small incision cataract surgery. Then Dr. Ms Ravindra, he is my own friend. At the last 30 years, I know him personally. So he was previously, I know he was at the Alliance Hospital, Bangalore. Now he started his own clinic at Bangalore. He has a MD from All India Institute. Then he has a fellowship from Shankar Nethralaya. It was in Retina. Then he has a fellowship from Cornea at Rochester University, USA. Now he is the chairman and MD of the Kartik Nethralaya Bangalore and managing trustee of Netra Jyoti Foundation Bangalore. He is one of the international surgeon in cataract surgery, especially small incision cataract surgery. Welcome, Dr. Ravindra. Then our third speaker is Ashish Kuriwala. He is a son of Dr. Philip Kuriwala. He has his education from CMC Vellore, MBBS, MS, DMB, and a past years Glasgow. And he has a fellowship of Retina from Giridhara Institute, Cochin. Now he is with Aradhana Eye Hospital. He is a comprehensive ophthalmic surgeon doing everything in ophthalmology. Main concentration is cranial focus surgery and focus surgery. Then we have Professor Jacob Koshi. He was a professor of ophthalmology at Ludhiana, CMC Ludhiana. Then when the Believers Church Medical College started in Tiruvalla, he shifted to Kerala, Tiruvalla. Now he is a professor and HOD of ophthalmology. As well as he is the dean of the undergraduate program. He is a fantastic focus surgeon as well as small incision cataract surgery. So today he will be handling two topics. So welcome all these speakers. So I hand over to Dr. Philip Kuriwala.
Yes, now we are ready for the scientific sessions. The first talk will be by Dr. Ms Ravindra. He's a fabulous surgeon, and I have a little warning to the youngsters who are starting to get ideas from him, but just don't try to copy him immediately. Take your time to do it because you cannot always just imitate without much training. So over to Ms Ravindra.
Yeah, I am indebted to Dr. Philip and everybody else in the society which has been delivering a fantastic day-long webinar today. I'll straight away jump into my topic. My topic is how do I make tunnels and how do I make my nuclear extractions. So I'm sitting on the upper temporal aspect. This is the right ear of the patient. That's a medial canthus, and a drape has to be applied adequately. You know the betadine, paracaine, and all those things is done under topical. I've been doing it.
Hey, your screen is not visible. The video is not playing.
Video not playing.
Only your folder is open.
Okay, it's not playing now.
No, it's not playing.
I think you have to share it from the bottom.
Okay.
The button above play.
About now?
Yeah, yes, sir.
Fine. So this is the right eye of the patient, and the draping and all has been done. And how do I start my surgery? Initially, I put a small swab there, cotton, and somebody else from outside, unsterile person, will drop few drops of paracaine. That is the tunnel area. That's the area I'm going to sometimes hold the fixate the eye. There's no superactive suture. I've taken the incision of both the conjunctiva and the tenons together. One blade that goes inside actually goes on the surface of sclera. The width of the conjunctival incision is only about 6 millimeters. It's not beyond, and I have not retracted the conjunctiva behind. This is one way. I'll go to the next video. That's a mature cataract. Same thing I'll repeat. Conjunctiva tenons incision 6 millimeter
The
wide.
screen is gone again.
Uh-oh.
You have to share the screen once again.
Is it sharing or no?
Not yet, sir.
Not yet, Dr. Ravindra.
There's a button above play. You that play above top.
I'll share again. A lot of windows are open.
No, above there's a button play. Left side.
Okay, I'll just go out. How about now, sir?
Yes, now it's on.
Yeah,
Hearing?
yes, it's fine.
I'm sorry. The conjunctival tunnel, an incision is made like that, and then that's a marker which marks 6 millimeter on the surface. Initial incision has to be very shallow. Don't take it more than 1/3 or 1/4, just a scratch. If you take it too much inside, then it will cause a lot of astigmatism. This meridian gets relaxed. So it's just a scratch incision. Then you take the blade here, crescent blade, and the incision that I made here is only that much, 6 millimeter, 2.5 millimeter, 6 millimeter, and 2.5. That's a rectangular incision tunnel I made. And then I enter the chamber with just a tip of the keratome, and I'm injecting air followed by trypan blue from the same syringe. And then do the rhexis. Rhexis is not my part of surgery. Somebody else will talk about it. And then to complete the tunnel, I'm making a 6 millimeter wide incision into the anterior chamber. Then continue the nuclear management.
Why are you changing it constantly?
I'm not sure why it's happening. I'm not sure.
So you go to the next if you want to show.
Yes, that's what I was doing it. Yeah, there is another type of tunnel that you can make. It's called translimbal. You have to anesthetize that area and that area. Only
Double
two
click
areas.
there, na?
Is it visible now?
No, it is just
Not visible.
No.
it is not showing your video.
Showing the folder, sir.
Video not playing.
Double click karo na uska.
Double click that video.
No,
Or right click and play. Or right click and play. No, it's not playing, sir. It's not playing.
I don't know what's wrong.
No, double click on the video. Either double click or right click and play.
Now is it visible?
No.
No, sir.
It's never happened. So
You are a technically sound person. So this problem should not come.
no, there is. How about now, sir?
Yes. Now it's on.
okay. Now just remember what you did.
This is an eye. I'm take the incision translimbally. Fixation is at that point. We'll have to put a topical anesthesia there with a cotton swab and another here. And I'm taking a 2.8 millimeter keratome. The entry is either the back of the posterior end of the limbus, the blue zone as you can see, or even in the anterior. I'm not raising the conjunctival incision at all. I'm going parallel to the cornea stroma, and you can see a dimple here as I press it down, and after that, I again lift the tip of it up there. If I go like that, the tunnel will be of a crescent shape, which I do not want. I want a straight entry into the eye. The tip of it is again entered up, lifted up, as you can see here. Lifted up and go parallel to the limbus, parallel to the corneal dome. And then you fill it up with viscoelastic and quickly complete the rhexis. And then again with a 5.2 millimeter tunnel, you are going to enlarge the wound to exactly 5.2 millimeter. Why it has to be 5.2 millimeters is whenever you are calculating the surgeon's induced astigmatism, it will be very convenient to compare one to one. The entry here, as you can see here, entry here exactly, there's a small congenital flap there, and as you can see, this incision is right there, it's rectangular. This actually creates no astigmatism if you enter from the middle side. If you enter from the limbal side, posterior limbal side, it will cause about half the PSI. That's the nucleus management. You saw one of them. I'll go back. Finish the rexis. Only the capsular separating hydrodissection. Capsular separating with a short tip hydrodissection cannula. This is a 2 millimeter tip hydrodissection cannula. Rotate the nucleus, lift the nucleus one pole out of the eye, rotate it into the anterior chamber, then bisect it. That's a special small microvectis which entirely goes inside the anterior chamber and closes the anterior chamber when you're injecting the, as you can see here, it's entirely in the anterior chamber. Then you keep injecting viscoelastic in front of the nucleus and remove the two heminuclei, and that's the end of the surgery once you implanted the IOL. There are a lot of files open. That's the reason why I'm. Is that visible now?
No.
Not the video.
Not playing.
Not playing.
There's something basically wrong. How about now, sir?
Yes.
Yes?
Fine now.
Fine, okay.
Yeah, it is fine.
This is about nucleus management. I have put a lot of nuclei being managed here during the surgery. Here I'm doing a larger axis. I'm holding this here only at that point. As you can see here, this is a 6 millimeter tunnel, and I have hydrodissection, capsular separating hydrodissection, facilitate, rotate the nucleus as I showed you just now. Bring it to the anterior chamber and protect it from damaging the I've done a very hard nucleus. There's no need to enlarge the. This is intratunnel fracture. I've taken a large wire vertex and holding it is injecting so the endothelium is separated from the moving nucleus. So viscoelastic HPMC is ideal. Align it to that and then bring it out. So depending upon the nature of nucleus, you can decide what is best for you. I've done a rexis, little smaller rexis. I would have liked to make a larger rexis than that, but still with difficulty, you could bring it to the anterior chamber, and once it is in the chamber, it's a time bomb in the sense that it can damage the endothelium if you're careless. This is a snare, as you can see here, which can be manufactured in your own OT. There are a lot of videos as to how to do it. Dr. Jain is the one who initially promoted this, followed by Dr. Devashish. Any kind of nucleus can be easily broken down. 6 millimeter or even 6.5 millimeter tunnel, hardest of nuclei can be removed it, but continuously keep injecting with this cannula viscoelastic to not to have endothelial damage. Once you've done, it's good, and that's another case. You have done a hydrodissection. That's the older cannula that I was using it. Bring it up and see that you're doing a hydrodissection, separating the cortex and the capsule. Then you will, what comes out now is a combined nucleus and epinucleus. Epinucleus is very difficult to remove, and it's always, it doesn't come out with the aspiration, doesn't come out like a nucleus. and difficult. And here, nucleus, epinucleus is separated, is not separated, they come out easily. Initially, when you want to shift over, you can make a scratch incision here, which is again should be very superficial. Don't go very deep because otherwise you'll end up with a lot of astigmatism, hydrodissection. It'll go fast. The technique is similar. But very small capsular excis, but you can still bring it down by manual rotation into the anterior chamber. Bisect the nucleus with continuous injection. Remove one. Don't try this unless you're very comfortable in infusing continuously the viscoelastic in front of the nucleus. Remove it. Small pupil do not come in the way of your nucleus management. Make the initially you remain within the pupillary area, but once you've crossed half of the pupil, you see that you go under the iris. You go under the iris and try to make it bigger, as big as possible. Extract it bimanually. You can lift it up bimanually and rotate it into the anterior chamber. You can keep injecting viscoelastic. See that the nucleus is cajoled into the anterior chamber before actually you're taking it out. So that's the lens is being inserted because that's a 6 mm opening. You can comfortably insert it into the capsular bag. Ensure that leading optic goes into the capsular bag and fold it and introduce it. So through a 2 to 3 mm, you can complete it. At the end of it, you want to close it with a drop of fibrin. Fibrin glue is always available in the OT because corneal surgeons are using it. The leftover fibrin glue, you can use it for your surgery. What if it runs off? Look at this. Trying to make a good rhexis, but suddenly it gives way. And this side also, because I had touched that side with the tip of my cystodome, that also gives way. So now you can make tiny incisions, create a sort of a rhexis there. It's not full rhexis with true breaks, but still you can comfortably handle this nucleus, bring it to the anterior chamber without putting extra pressure at the two areas where the capsule is weaker. Bisect it. If it doesn't break, you can use the cystodome, bisect it. It's quite hard. It's gone inside. It slipped my hand and went inside, but still did not cause any problem to the capsule. And you can inject the lens there and see that the arcs of haptics sit on the intact side, not on the weak side of the capsular bag. Yeah, you can. That's what my presentation. I've got one more video, but then we can show it when there is time. We can show it.
Thank you, Dr. Ravi. I think we are running short of time. We have 4 more speakers. We have beautiful videos with making tunnel as well as different method of nucleus management. I think I have a common discussion towards the end. I invite Dr. Ashish Pirola. So he will manage. So one of the problem with the surgery SICs is astigmatism. So Ashish will be enlightened how to manage the astigmatism in small incision cataract surgery. So finally, after all the speakers section is over, we can have a common discussion, question and answer. You can start, Ashish.
Can you all hear me?
Yes.
Yes.
I will just following up from where Dr. Ms Ravindra sir has said. Of course, I'll be talking more about a theoretical thing which doesn't have much of relation with surgery. That's what we do mostly in our institute. We do a transconjunctival section, normally 99% of the time temporal, and we do mostly a frown incision. Sometimes we do a straight incision with back cuts, and then using a crescent blade we enter through that transconjunctival and through the sclera. And once the depth of it is ensured, once you enter into the cornea and you're sure about the depth, then the side connections are made, and a pocket is made through the sclera and the side as well to ensure that there is vacuum sealing of the tunnel. And here you can make out that actually it is quite limbal, the incision is quite limbal, and therefore the internal lip is actually extended almost more than 2 millimeters here. But in this particular case, it was alright as this patient had pinpoint pupils undilated. And so probably this will not cause much of coma or trefoil postoperatively in this patient. So and the SIC is related astigmatism. Why is it that we don't have much information about SICS and good randomized controlled trials as far as astigmatism is concerned. The main reason is the complexity in the incision of the tunnel itself. So in order to have a proper study, you need to have certain protocols, fixed protocols as to how to do the incision in every single case. And as we all know, in SICS, if you're making a tunnel the traditional way, then it becomes difficult. Of course, sir just showed us now how we can make a 5 millimeter, 6 millimeter incision and consistently have a 5.2 millimeter incision, and that way it is much more reliable. But the traditional way that we do, where we make a scleral incision and then we go in through a tunnel and then have a lip with the cornea, presents a lot of complicated issues which you have to deal. So the external lip, depends on the grade of the cataract and the size of the cataract. That has to be taken into place. In the tunnel, you must know what depth you're in, and also the length of the tunnel is very important as the final astigmatism. As we all know, it depends on how much we are going into the sclera and how much we are going into the cornea. So these have a bearing on the final astigmatism. Also in the inner lip, it's very difficult for us in SICS to mark exactly 2 millimeter, 1.5 millimeter inside the inner lip, the distance from the limbus to the inner lip. At each point in the inner lip in an SICS incision, you will find that the distance from the limbus is different. So it is very difficult to objectively make scientific protocols as to how to make the incision, how to keep it consistent, and to the induced astigmatism based on that. So all these factors actually change the astigmatism, and to just say a 4 millimeter incision produces so and so astigmatism, it is not as straightforward as that. If it were a straight incision without a tunnel, without this trapezoid sort of trapezoid sort of shape, it would be a lot easier to make direct assumptions like that. So, but there are some things that we can do, and which are known things in to reduce astigmatism. Very basic things like cautery. Don't apply too much of cautery. If you apply, then the seal will not be perfect, and post-operatively you will have a lot of irritation, and the bed of the sclera will not oppose well, and the vacuum closure will not be thing. And do not stretch the tissue too much, and therefore you should make sure and be confident that the nucleus can come out through that tunnel. Therefore, whatever method necessary has to be done in order to make sure that the nucleus will come out easily through the tunnel. So if you stretch it too much, micro tears will be there, and that will compromise the integrity of the tunnel and therefore lead to astigmatism and flattening in that particular axis. The other basic thing that we have to know before doing, of course, this is for people who are just starting off SICS, is that before we think about astigmatism, you have to think about whether we can make a consistent and perfect tunnel. So therefore, here in this case, if you make a first initial incision itself, it is very deep, and then somehow we manipulate and make a tunnel and enter here, this will produce a severe astigmatism because you are essentially doing a sort of Arket Keratotomy at this plane, or an ECC type of wound at this plane, and this is not going to improve your astigmatism in any way. Similarly, if you make a very small incision, and I go through like that, after somehow managing to adjust it, you will find that it will be almost like doing an Arket Keratotomy at this plane, and the incision at the internal lip is quite huge. Therefore, you can imagine the type of astigmatism we may end up if we make a superficial incision and then somehow adjust it. So a consistent one where 50% or 60% of the scleral thickness is maintained and then entry is done is first to be guaranteed before we think about improving our surgical induced astigmatism. So one of the most basic and oldest things we know is that the Cox astigmatic tunnel should be maintained. So here we can see that incisions such as this, where as we all know, the incision will produce more astigmatism. The more curved you make it, less astigmatism will be there. Therefore, this kind of incision, as the few later speakers will talk about, will produce less astigmatism. And further from limbus will be better. So therefore, this obviously will produce more astigmatism, and as we go above posteriorly, will produce less astigmatism. So for surgeons who have done thousands of cases, they know exactly what nucleus will come out through what tunnel. Therefore, that does not have to be told. But I think for people who have not done many cases, there's one thing that you have to make sure: don't try and make too posterior an incision on the sclera, because the nucleus coming out through that will be definitely technically more difficult. And so, in the aim of reducing the astigmatism, we should not cause damage to the corneal endothelium, and therefore it is probably key to be comfortable to make incisions at this level than at this level before you try to venture into making posterior incisions, if that is what you may be interested in. The other thing that we have to notice is the size of the cornea. The size of the cornea is very small, 10 millimeters versus a standard 12 millimeters. You will have to make an internal incision that is the same, irrespective of the size of the cornea. So here we have a large cornea. You can see that same internal 8 millimeter incision is quite far away from the optical center. Therefore, as we all know, the astigmatism also increases as you make the cut closer and closer to the optical center. Here it is, of course, this is an exaggeration, but just to put the point across. So here in Arket Keratotomy, the main this thing here is the length of the incision. As we all know, the concept of the Arket Keratotomy is that the larger the incision, you will get more astigmatism induced. And the closer and closer you go to the optical center, the induced astigmatism is more. And also Arket produces less astigmatism as compared to the transverse incision. And since transverse produces inconsistent results, mostly people do the kind of a curved keratotomy rather than the straight. So getting still normal size 10 millimeter that has to be pulled out through this AC. It may totally fill the AC and still has to come out without much negotiation. Therefore, the trick is to make not a straight but rather a curved incision. This will produce less astigmatism. And as we discussed further, the distance also will be increased if you do an incision like this. But one must be very also of airtight and sealed, and then the tunnel integrity must be maintained. So therefore, you must know how weak the tunnel is. And if you make an incision like this, you cannot make a limbal incision. You will have to go further into the sclera to make sure that this area is not weak as far as the tunnel is concerned. So these things, I mean, after you do a lot of cases, you will know naturally. But initially, you must be very wary of these things as you start off, especially. So make sure in small corneas that the incision, you plan out the tunnel perfectly, because otherwise the induced astigmatism will be more. This is something that most speakers have talked about. Superior incisions produce larger surgically induced astigmatism. So in our place, mostly if it is more than 0.75 diopter, we go for superior. Otherwise, we go for temporal incision. And why is it that this 0.75 diopter number is because as age progresses, anyway, whether the surgery is done or not, slowly the width rule of most patients go into the against rule, irrespective of the lens status. And the other thing is that most of the posterior corneal curvature has an against rule effect. Going to the explanation a little more, actually the with rule cases, what we see in more than 80% of the cases is that the posterior corneal as curvature is steep vertically, and since it is a concave surface, the final effect is the against rule. So finally, with the rule, we will lead to overestimation in more than 80% of cases. Therefore, a 0.5 diopter that you may be seeing at with the rule may in 90% be actually 0, up to 0, or maybe anything between 0 and 0.5 diopter. Therefore, if it is a large rule astigmatism, surgical superior makes sense, but otherwise speaking, against the rule makes more sense. Of course, as far as the posterior corneal curvature is concerned, the posterior corneal curvature in against the rule cases is actually equally distributed with against the rule and oblique. So you cannot make any logical guesses as to what it can be. So it is a little less consistent as far as this is concerned. With the rule, most cases have an against the rule, and so overestimation in most cases. So then should everybody move on to corneal topography for every single case? Recently, Dr. Douglas Koch from US, who is one of the pioneers of making these formulas and latest regression formulas, he has said that in his study, he does a lot of studies on biometry and final postoperative vision and all that. He has said that presently, today, regression formulas such as Barrett's 2 universal are equally as good as doing a topography. You do not need to do a corneal topography which has Schleimpflug imaging and posterior corneal curvature assessment. Of course, if you have a topo in your institution, well and good, but otherwise, regression formulas as of today is good enough. So these are the 10 things that we had discussed about. Avoid extensive cautery and stretch cornea, and make sure the size is adequate, and consistent depth and uniformity of the tunnel is important. The external lip, start with straight and then move over to more curved incisions if you want to make less astigmatism, or as Dr. Ms Ravindra sir showed, modification of the traditional incision, and then do further away from the limbus, and that will be better. The internal lip shape, better to be curved, and not straight, because the straight ones will be like a transverse incision, more astigmatism. The smaller corneas will definitely cause more astigmatism if you're closer to the optical center. So we have to be very wary of that if you're doing SICS in these cases. Superior incision will produce more, and therefore think about doing cases which are temporal incision, and always be wary of posterior corneal curvature. Therefore, I suggest most of us are shifted to Barrett's 2, and I would suggest everybody to probably shift to these regression formulas, which we incorporate, theoretically incorporate the posterior corneal curvature. Thank you so much.
Thank you, Ashish.
Ashish,
Yes, sir. Yes, sir.
yeah, you have come very close to doing some research. Why don't you focus a little more?
Yes, sir. Yes,
Because
sir.
we are always quoting the West for our
Yes, sir.
experience, but why not? You have come very close.
Yes,
So now take up some studies and these things now. Let us have our own things.
Yes, sir. We
And
definitely
at
have
this
to do.
point, I will tell you that Boramani has done an algorithm of wound modulation, estimating free SICS. I think we should have a webinar on that specially.
Yes, sir. Yes, sir. I think that probably we'll have to discuss with sir also about the raw data, incisions, supratemporal incisions, and in sir's, he's done a lot of topography and post-operative cases, and he's got very consistent results.
Temporal incision, always you take, or you take it to whenever you have some
If it is
indication for it?
actually, sir, nowadays, if it is with the rule that it's a lot, we actually, instead of superior incision, we actually use toric lenses more nowadays because we are so comfortable with temporal. But I think more than one diopter, it is a good idea to do a superior incision for correcting.
Yeah, because
that.
temporal do not correct any astigmatism.
Yes, hardly anything. It doesn't change much, sir, post-operative.
Yeah.
That is what we have found.
But anyway, I will expect that you do take up some research. See, we are, as you say, we are service provider. That should go now.
Amulya sir, we have a
Yes,
common
sir.
discussion to the end because 3 more speakers are there waiting. We have to close by 7 o'clock. Thank you,
Yeah.
Ashish, for the wonderful, because a lot of diagrams you have demonstrated how to put the incision so that stigmatization can be reduced. Now I invite Dr. Pirula. So sir will be talking in the 3 millimeter incision for cataract surgery. So he's a wonderful surgeon doing this with a very small incision he does in cataract surgery, and he is also top on toric IOL implantation also. So over to Dr. Pirula.
Yeah, thank you very much. Am I on?
Yes, you can hear.
Can you hear me?
Yes,
Yeah. See, this is a 3 millimeter incision. It's a good choice if you're doing a superior incision to minimize astigmatism. But if the surgery is done temporarily, most of the surgeries we do temporarily because we find that it's very difficult to introduce astigmatism with more than 0.5 diopters of surgically induced astigmatism if you do temporarily. But if you are a compulsive superior incision surgeon, then we can consider this 3 millimeter incision. Also, it is a good choice if you're doing an SICS along with a VR surgery, because VR surgeon is somebody else. I don't do VR surgery, and they don't like you to make a temporal incision as it comes in the way of a surgery. So we are forced to do a superior incision. At that time, we can consider this 3 millimeter incision.
3 millimeter manual SICS, also known as tiny incision cataract surgery. This is done under topical anesthesia. A 2 millimeter incision is made at the limbus and back cuts given. Back cuts are minimally diverging so that effectively it is about 3 millimeter. Scleropod and sclerocorneal tunnel is made. Anterior chamber entry is done using keratotomy, and it is extended sideways so that internal incision is about 7 mm to 8 mm. Visco injection is done. Capsulorhexis is better done under a dye, but in this case, dye was not used because the glow was good. Capsulorhexis is completed and a cruciate incision is made over the cortex. Under the AC maintainer, hydrodissection is done. A part of the nucleus comes into the anterior chamber. The rest of the nucleus is rotated into the anterior chamber. Nucleus delivery is done with a hook and a serrated vectis using the sandwich technique. The serrated vectis used here is designed by Dr. Philip Kuruvilla. It is serrated and narrow and not as big as the usual vectis. The cortical wash is done with just an ordinary cannula. AC maintainer is there, so it keeps the anterior chamber and prevents the intraocular lens is loaded the usual way. And it is injected into the bag. Dr. Philip Kuruvilla does not usually use visco before intraocular lens implantation, but sometimes he does. One advantage of not using visco is you don't have to wash it off. You can do minimal washing after the intraocular lens insertion. Stromal hydration is done, and as you can see, the case was done under topical anesthesia. Thank you.
Now we will go on to the second topic, SICS and toric IOL implantation. I do this quite routinely. We do it in our place. Many SICS surgeons are reticent to do it. I don't understand why. I thought the SICS, if you are good at it and if you know how much astigmatism you produce in your hands, we can calculate the toric IOL and then introduce. If it is more than 1.5 diopter cylinder only, I do the toric IOL implantation. Contraindications are irregular astigmatism, presence of pterygium, nebular opacity. If the eyes are dry, it is difficult to assess the values, so then it might give you an inaccurate readings. Proper counseling is important. Don't guarantee elimination of cylinder, rather better clarity by reducing overall astigmatism. If the patient is having 3 diopter of cylinder, if you reduce it to 1 diopter or 0.5 diopter, patient will be very happy because all his life he was with 3 diopter. So we should not be discouraged if the cylindrical thing is not completely eliminated. In fact, when it is completely eliminated, he is a little unhappy. Dr. Ashish had a case 2 weeks ago. Because of toric lens, the whole lens of 3.5 diopter cylinder was completely eliminated and he was not so happy. So, anyway, accuracy in pre-op biometry is absolutely critical. K from autokeratometer, corneal topography, optical biometry, even manual keratometry. One thing is that we want to measure corneal astigmatism and not lenticular astigmatism. Lenticular astigmatism will disappear when cataract is removed. So we ignore refraction values which will include lenticular astigmatism. The marks are done before, and I do a mark here mark here, that is 180, and 3 o'clock and 9 o'clock. You see maintainer right through this section. Nucleus is rotated into the anterior chamber, serrated rectus, and a sharp hook to sandwich it out. The cortex is stripped with a simple cannula. I don't use simple cannula. A good toric lens is important because some of the lenses I found is not so accurate. The alcohol lens is good, no financial interest. You get fairly accurate values. This has to be position it. Just rotate it. It is probably good to rotate it under the scope. And this is the first post-op day, and you will find that it is sitting in position properly, and that's it. Thank you very much for your attention.
Thank you, Dr. Philip. Can you hear me?
Yes.
Sir. So thank you for the beautiful videos. So we will go to next speaker, Professor Jacob Koshi. So Jacob has two talks. First he will be talking on mainly secondary IOL implantation. First will be posterior fixation of iris claw lenses, and second will be scleral fixation of IOL. So both are secondary IOL implantation. First will be iris claw lens, followed by scleral fixation of IOL. Over to Dr. Jacob Koshi.
Good evening, everyone.
Yes, yes.
Yeah, thank you very much. At the outset, I would like to thank the organizers for having me here. We wish...
Can you talk louder, Dr. Jacob? Can't hear you well.
Can you hear me now?
Little closer. It's a little closer.
Is this clearer now?
Yes.
Yeah. At the outset, I'd just like to thank everyone for having me here. In the interest of time, I'll go straight ahead. First, I'm going to be talking about retrofixated iris claw lenses. These are iris claw lenses that are fixed behind the iris. And it has been shown that these lenses have a very good visual recovery, have a very low risk of post-operative increase in IOP, and is a time-saving method, and is an easier technique to do than scleral fixated lenses. Iris claw lenses also have a very good visual outcome and can be used for a wide range of indications, as I'll show you a little later on. And it is a very safe procedure and an effective option for aphakic eyes without capsular support. Now, this is an aphakic patient who has come for surgery. You can see that there is no capsule. The patient already has a peripheral iridectomy done. This is an ideal case to start doing iris claw lenses if we are just learning. A superior tunnel incision is made like in every S case. The two side incisions are about 2 millimeters wide.
Video has not come. Video has not come.
Can you see the video?
Video not
is the video playing?
No.
Video is not playing.
No.
Video not playing.
I shared the video. Can you see the screen? Is the screen on?
Yes, yes. Full
No.
screen is seen.
No, only your
You can see your face, but not the screen.
face, not the screen.
Now can you see the screen? Are you seeing the
You
screen
can
now?
see,
Okay.
join
Yeah,
and
we
meet
can see.
screen, yes.
I'll go to the video straight away.
But it's the same.
Can
It
you-
just
can you-
same, it is Zoom meeting screen, not your presentation screen.
I don't know what's happening. Can you see the screen now? Is there anything on
No.
right now?
No.
I don't know. Is the IT person here?
No, you're already online on Zoom, so it doesn't, this screen is not required. Close the screen, please. Let's see what happens.
Yeah. What is coming on your screen now?
The Zoom cloud meeting screen.
You minimize that screen.
Yes.
Yeah, you minimize that and you open your presentation.
Yeah, my
Minimize the
presentation is,
screen.
I've minimized that and I've opened my presentation. But
So
What we are seeing is your Zoom screen.
Can you unshare your screen again? Share your screen, sir,
okay, I'll do that.
and select option screen.
Share screen.
The first option.
Yeah.
After, yeah, then there will be 2-3 options. So you select the one option that is screen.
Screen.
The first
Yeah.
option.
Yeah, I double clicked on that.
Yeah.
Now is the presentation.
Now click the, now click the presentation.
All right, I'll go straight to the video. Can you see the
Yes,
presentation?
we can see.
Now it's come.
I'm sorry about that. Okay, I'll go to the video straight away. This is a patient who has, who's already aphakic, and you can see that a small peripheral endarterectomy has already been done. This is a good case to start doing retrofixated iris claw lenses. Superior incision is made like a regular SICS. 2 side incisions are made about 2 millimeters wide. You can use any knife you want. They are exactly 180 degrees apart, and this is crucial for this kind of surgery. It should be 180 degrees apart. Here, just like a routine small incision cataract surgery, a tunnel incision is being made so that you can leave it sutureless if you'd like to. An entry is made into the eye. And this inner lip is only about 5 millimeters in size. A good anterior vitrectomy is mandatory, and never any of these procedures should be attempted without doing an anterior vitrectomy. Pilocarpine is injected into the eye, and you can see that once a good anterior vitrectomy is done, the pupil goes down right in front of your eye. And we need to bring the pupil down to about 3 to 4 millimeters in size, and this is an ideal size to bring down the pupil to. This is an iris claw lens. There are various models available. I have no financial interest in any of these, but this is an iris claw lens, and you can see that the central optic is there, and then you have that haptic on the side, which has a small break in between. It's not a continuous edge of the haptic. This is now positioned, and you take a forceps and hold it right across the optic. This is crucial. Otherwise, if it slips under the iris, you might lose the lens. So make sure you're holding it all the way across, and then you can go in from the side, and this haptic is enclaved by just pressing down on the iris there. As you can see there, you'll get a give sensation. You can do that once or twice to be sure that you've gripped it. Now at this stage, you need to change hands, and you can see now a dimpling on your left where it is already fixed. Now you hold the optic with your left hand and you go in with your right hand. This stage you need to be careful not to manipulate too much, otherwise you can cause an idodialysis. Using the right hand, we just slip the iris over the lens and then go in through the side port, and the same procedure is done to fix the lens. You can see that you get a give sensation there. You can do that twice to be sure that you have enclaved the iris, and then you can come out. Here I'm just taking an instrument and tapping down on the lens. You can see how beautifully it is fixed. Unless you look very carefully, you will not be able to differentiate this from a regular PCIOL, and that ends the surgery, and you have a beautiful surgery at the beautiful outcome. The next case that I'm going to show you is a traumatic subluxated lens, and as you will see here, the lens is nearly totally subluxated. There was no way of salvaging the capsule, and when you go in with the vectors, the whole lens just comes out. It was just barely hanging in there, and this lens is now brought out, and as a primary procedure, it was decided to do put a iris claw lens. An anterior vitrectomy is being done. And once anterior vitrectomy is done and pilocarpine is put in to bring down the pupil, this lens is now being placed in position. We first leave it over the iris, and then once you hold it carefully, you can see you can enclave any end. Generally, for a right-hand dominant surgeon, you might want to enclave the left side first, because the second side is always the tougher side to do, because you want to keep manipulation down to the minimum. But you're free to enclave any side first, whatever you're comfortable with. And you hold the lens. The grip on the optic should be good so that the lens doesn't slip out of your hand while you're trying to enclave it, and you might lose the lens, which you might need a retina surgeon to help you with that. This is another indication, and you can see that this is an anterior chamber lens lying there, which is leading to some amount of corneal decompensation. You can see that there is pseudo-exfoliation in this eye, probably leading to the initial surgeon leaving an anterior chamber lens over there. And because of the decompensation, it was decided to explant this lens, and an iris claw lens is a good option for this. So the anterior chamber lens is brought out of the eye. I cannot emphasize enough a good anterior vitrectomy to make sure that there's no vitreous in the anterior chamber. You don't want any tags pulling on and causing retinal issues. Make sure you grip the optic, as I mentioned, right across the optic to get a good grip. And then once the first end is enclaved, you switch hands, and now the second side, the optic is held. Always go in with your right hand to slip the iris over the lens. You don't want to manipulate the lens too much at this stage once one haptic is already been enclaved. The second side is being enclaved there. You will notice that there is a small dimpling over there. A word of caution here, never do these iris claw lenses. If you have iris atrophy, they'll tear over there, and you might land up in trouble. This is another patient who came a couple of days after his primary surgery, and again you can see there's no capsule. There's a posterior chamber lens predominantly lying in the anterior chamber, and you cannot leave this patient like this. So it was decided to explant this lens and do something about it. So you can see the entire optic and one haptic was already in the anterior chamber. Here I'm slipping this original lens out of the eye. There was no way to use this lens because there's no capsule there, and an iris claw lens is being fixed back here. And once the surgery is done, we always tap down and make sure that that it is enclaved well. This is an instrument I just wanted to show that can be used, which has a T kind of surface underneath. For those who are starting, if you get this instrument, it helps in holding the lens much easier. This is much easier to use than a regular intraocular lens forceps. This is another patient in which an iris claw lens is being used. Always bring down the pupil with pilocarpine before the surgery is done. You cannot enclave these lenses when the pupil is dilated. You'll end up with a oval pupil, and it will not look good at the end of the surgery. Even if you manage to enclave it, the pupil there will be marked ovalization, which is not what you want. a word of caution, always in these iris claw lenses, we must do a peripheral iridectomy if it hasn't already been done. Usually I like to do a laser iridotomy before the surgery, but in case that is not done at the end of the surgery as is being done here, you can use a vitrector to just make a small hole there and make sure that you have a intact peripheral iridectomy at the end of the surgery before we close up. Thank you very much. This is the end of my first presentation. I'll quickly do the other presentation as well so that
Yes, continue with the scleral fixation.
can you see the screen?
Yes,
Scleral
yes.
fixation. Yeah. So I'll be talking also about scleral fixated lenses, and there are many techniques with scleral fixated lenses. I'm going to be only talking about 4-point fixation. In this, I will be talking about 3 techniques that I do in increasing difficulty level. First, we'll talk about the standard 4-point fixation. Here we use a double arm long needle Prolene suture, and this is 9-0 suture that we use nowadays. And this suture has to be passed through twice through flaps which are created 180 degrees apart from, and which is away from the main wound. Once this is done twice, we end up with something like this, and then we pull the suture out of the main wound with the help of an instrument, and that suture is cut there, and then it is anchored to the 2 ends of the lens of the scleral fixated IOL, which has holes in the haptic, as you can see there. Then this is pushed back into the eye, and it is tightened and sutured there, and that fixes the lens, and then you close the flap. So this is how we do a 4-point fixation. And here I'm going to show that to you. Is the video visible? Okay. So here, this is a patient who has had a trauma and has a primary lensectomy. Part of the iris is also missing. You can see the old surgery scars there. And now there is no way, even an intact iris, I would like to put an iris claw lens, but when you have a patient like this, you have to put in a scleral fixated lens. So you can see the tunnels are being made just like we do a trabeculectomy, but these 2 tunnels have to be 180 degrees apart, away from each other. So 2 triangular flaps, you can also make a quadrangular flap. And then the main wound is open just enough to pass the lens into the eye when required. Here the 9-0 suture is being used. You can see the long Prolene needle that has to be used, and one side it is pushed. We need to be careful to go straight down so that we avoid the root of the iris and ciliary body, otherwise there will be bleeding. On the other side, we have a curved 26 gauge needle which is being passed through. And then using the handshake technique, the long needle is passed into the groove of the 26 gauge needle, and that is used to exteriorize the needle and to get one pass out. And you can see that the needle is being held, and when we pull the right hand out, you'll have the edge of the long needle sticking out of the eye, which is then pulled through to have the first pass. Now this suture that we use is a double arm long needle suture. So without cutting the other edge, now the other edge is passed. Over here you get the first bite through, you have the 26 gauge needle. Here again, a good anterior vitrectomy has to be done. So sometimes the eye is soft and it's a little difficult technically to do this, but it can be done. Once the sutures are passed through, here I'm using a Kuglin hook. You can use a Sinski hook or any hook that you have, and the sutures are brought out of the main wound. Once it is brought out of the main wound, we now just cut that with the scissors. This is a scleral fixated lens. You can see that hole that is there in the haptic, which is not there in our other PMA lenses. The suture is passed through this hole twice. You must pass it at least twice before you tie it, otherwise the suture will just ride through. And then knots are tied. These knots, you need to tie 8-9 knots. We must remember that we are using Prolene here and not silk. Unless you tie multiple knots, the knots may open up. Therefore, in locking sutures, we tie about at least 8 or even 10 knots to be sure that they don't give way. Now, both ends are tied, and then just like you put in a regular lens with the right side haptic leading first, we pushed it back into the eye. And then we pull on the sutures which are on the side to get the haptic into position. Now the left side is being dialed into position, and again you pull on the left side suture, and once both the sutures are pulled, you'll have the lens centering perfectly. At this stage, we tie both the sutures on either side outside the eye, and that helps to center the lens. You can see that the suture is being tied there on both ends. Once the suture is tied, you can see that the lens is perfectly centered. We now have to close the flap of the sclera above the knot. You don't want the knot sticking out because it can cause some erosion. We do a vitrectomy again just to make sure that there is no vitreous in the anterior chamber before we close. And then finally we close up with some sutures on the outside. You can put sutures or use cautery as you feel. Now, this is a lot of studies over the years have found that after 5-7 years, it is the suture at the knot which breaks in these scleral fixated lenses, leading to dislocated lenses. So this is another technique where we don't want to have sutures or knots within the eye. So here, instead of going across, the suture is brought out through the main wound. As you can see there, the suture is being brought out. This is a modification of the initial technique. Again, it is a 4-point fixation. Now the suture is passed through the haptic loops outside the eye. Here, no knot is being tied. Once a suture is passed through the loop, here you now have a 26 gauge needle going back into the eye, and the original needle is again passed out through the main wound into the side wound, and now you have the two ends of one side which have come out, and you don't have a suture, you don't have a knot inside the eye which can give way. The other word of caution, in the initial days we used, about 15 years ago, we used to use 10-oprolene sutures, but again that has found that they give way. So now the accepted standard technique is to use 9-oprolene double arm sutures. This is the safest that we know as of now. So this technique is more difficult because there's more manipulation involved, but you end up without having sutures locked onto the lens. The second throw back out of the eye is always more difficult when you're going from the main wound. So unless you've done a few standard SFIOL fixations, do not try this because this would be a little more difficult to handle. And then once it is done, the sutures are pulled and you can see that the lens centers well and fixates well. So this is the second technique. Now I'm going to show a third technique, and this is an injectable scleral fixated lens with standard 4-point fixation. This is now a patient, it's actually a small child who's had a primary lensectomy following trauma. And the pressures are also high, so we didn't want to disturb the conjunctiva superiorly too much to leave it free for any glaucoma procedure if required. So once the sutures are passed and now it is being exteriorized like we did in the initial surgery, here the surgery is the same. Now the suture is cut and one side of the sutures, that is 2 sutures on one side, are passed through the injector of the foldable lens. And once it is passed through, now it is being tied. Here a foldable lens with a C-loop haptic which has a hole in the center is being used. So you have the suture being tied to the leading haptic of the foldable lens. Nothing is being done to the trailing haptic yet. Once that suture is tied, the lens is locked into the cartridge just like we would with any butterfly cartridge. And this is now being injected into the eye. So right now we have only the leading haptic which is sutured. Now at this stage, as soon as the optic enters the eye, we must make sure that the trailing haptic is brought out outside the eye because the suture hasn't been tied yet. You can see the trailing haptic outside the eye. Now the other 2 sutures which are left are now tied to the trailing haptic which is outside the eye. If the entire lens is injected into the eye, then this procedure cannot be completed. Once the suture is tied to the trailing haptic as well, This is now rotated and dialed into position inside the eye while tugging on the suture to get it into position. And once it is dialed into position, you can see, and here it is done. And because it is a pediatric case, even though it was a small wound, I'm putting a suture there. So these are 3 techniques to do standard scleral 4-point fixation of increasing severity. Thank you very much.
Thank you, Dr. Jacob. I think Philip sir is there. Or Sahul, any addition? Only 2-3 minutes left.
Dr. P. Sasikumar, he would do a lot of all the cases under topical anesthesia. I think also there were surgeons who were doing under topical anesthesia. Do you want to make any comments? Dr. P. Sasi is there?
Yeah. I'm the same.
Yeah.
Am I audible?
Yes.
Almost I do the same thing what Dr. Ravindra did, sir, but I used to balloon the conjunctiva. Am I visible?
Yes.
I'm seeing Dr. Andrews' screen, so.
Yeah, I can see your screen.
Am I visible now?
You're glowing very much.
Fine. Okay, so same thing I used to do, but I used to balloon the conjunctiva, and once the pad is put and it's removed after 4 hours or something, it just gets plastered very well. So that's one thing I usually do temporal only. One thing I was asking Kurula's back, what I was asking was, does COVID, this era, does SICS has got anything more when compared to FACO people during this COVID era? I want to know from Dr. Kurula, sir. What's your opinion, sir? Are you there, sir? Kurula, sir? Are you there, Kurula, sir? Hello?
Yeah, in COVID season, I think SICS has a lot of relevance. Number one, there is a theoretical aspect of more aerosol being produced in FACO. Probably that is not so significant. The second thing is the SICS. It is more predictable, like you're not machine dependent, so you can do it pretty fast and send the patient off. So theater time is less, the less of tensions. Otherwise, the FACO machine may break down any time. The system may not have connected it properly, and the thing, many technical things can go wrong, and then you wait, and things like that. So such things, of course, are avoided. And in SICS, I think we are able to, it's more predictable time, and you can go off.
And even our packages, we can bring it down if needed, because our whole thing.
I think
package
part. Amulya sir, 1 minute, only 1 minute left. Amulya sir is there. So any concluding remarks, sir?
It's been wonderful, and all of you are very excellent surgeons. A lot of things to learn. Good thing for SICS. I think everybody had a wonderful video, and it's quite good. But I want the chapter to be more vibrant. It's the last 21st we installed the Telangana chapter. We have now 400 members. I don't know, Kerala being in the forefront of knowledge, why they are behind, I don't know. And Kurula is doing such wonderful surgery, as all these bright people are there, and but chapter is not that vibrant. I expect it to you take more work on that. Make the new chapter with
Okay, so I think
I look forward to the new chapter, and thank you.
Okay,
thank you, everybody, sir. Thank you, everybody.
Thank you all.
Thank you very much.
And now to Rohan.
Okay. Yeah. Now, next session, Rajesh.
To all the speakers.
Hello. Next session, Dr. Prashant is there.
Yeah.
Prashant.
I'm there.
Yeah.
Am I audible?
We can take over. Yeah, you are audible.
Am I audible?
Audible.
Yes, Prashant.
Yes.
Have the speakers. Okay. have the speakers come for the next session, all of them?
Yeah, I think so, yeah.
Yeah, okay.
Todd has to give the countdown actually.
Yeah.
Yeah, then only start. Anyway, you could give the introduction.
Yeah, okay, fine. So welcome to the last session of the PSOS Monsoon Spice. Now, if this was a one-day international cricket match, we would be probably in the exciting slog overs. And who better than the dashing Dr. Minu, our chairman of the next session, our own Mahinder Singh Dhoni, to lead us to the end of the session. An alumnus of Trivandrum Medical College and then Arvind Eye Hospital in Madurai, and presently senior consultant at Chaitanya Eye Hospital in Trivandrum, Minu has this unique ability to simplify and present complex subjects with a light touch. Obviously, only a master of his craft can do that. He is among always the fan favorites in the conferences he attends, and it was no surprise that our organizing secretary, Dr. Rohan, wanted him for the final stretch of our monsoon spice. It's also Minu's contribution that Dr. Lubeck from Chicago is gracing this session, something unthinkable for a modest club like PSOS. So welcome, Dr. Lubeck, and thank you for taking the time. The session is being moderated by our own dynamic Dr. Mrudula, who, apart from being a member of PSOS, is also a former president of PSOS. And I take this opportunity to welcome Dr. Jayaprasad from Kollam and Dr. Matthew Kurian from Kochi for accepting our invitation. So over to you, Minu. Let's finish in style. Good luck.
Thank you, Prashant. I hope I'm audible.
Yes, Enter is still not given the go ahead. Are we online? And
okay, then we'll wait for Enter.
Yeah, they usually give a countdown.
I will just check.
Yeah, they're all online. Raman is here. Where is Parikshit?
Yeah, but usually they give a 5, 4, 3, 2, 1.
It's, I think, a continuation of the same Thursday.
Okay, that's why we are not starting a new session.
Right. And we will say the section 4.
Okay, I think we'll straight go ahead with the phacoemulsification session. Thank you, PSOS, KSOS, and all the office bearers, especially Dr. Rohan, to introduce this session towards the end and have phacoemulsification little more time of 2 hours. And we have our guest faculty from US, Dr. Lubeck, joining us. We have this session moderated by Dr. Mrudula Sunil. And we have speakers, Dr. Jayaprasad, Dr. Matthew Kurian, and Dr. Lubeck coming in. Without wasting time, we will introduce the speaker as they come on to speak. And we will have some discussion after each session, but then we'll go on with the topic so that we'll finish in time and also have some discussion towards the end. And so, Mrudula, because Mrudula is going to talk now, do you want to say a few words?
Am I audible?
You're well audible.
Yeah, and on behalf of PSOS, I invite all of you for this wonderful session, which is, we know, like Minu is the one person who's known internationally, and he's the chairperson of this session. And I hope it will be of knowledge at the end of it. And we'll have, I think, as Minu said, we'll have the discussion at the end of the session. So can I start my...
Yeah, I think we will start with the first talk. This is by Dr. Mrudula. Let me introduce her. Need not be introduced to Palakkad Society, but then she has graduated from PSD Institute of Medical Sciences, Coimbatore, and did her DNB from Aravind, Madurai, and worked in the UK for 3 years, and she completed her FRCS from Edinburgh and Glasgow universities, and she came back to India and started the Trinity Hospital, which has now 5 branches, and it is almost 20 years now since she has been running the hospital. And she is a very prolific phacosurgeon, and let's hear from her the preoperative assessment and biometry in phacoemulsification. Over to you, Dr. Mrudula.
Thank you, Minu, for the wonderful introduction. And I share my screen now. Is it visible?
Yes, it has started sharing. It started sharing. Okay, come on. Slides are on.
I think you can
I
start.
think she has gone offline.
You've gone offline?
No, you're all right.
You're online, but then the slide is Zoom, so that has to be minimized.
Yes. Now can you see?
Yes, you can start.
Okay. So my topic, it's really a vast topic to be discussed in such a short time. So anyway, let me see. I hope I do justice to you. So regarding the pre-op evaluation, see, we all know history taking is a very important thing in as far as the decision making is concerned. So the patient comes with a vision loss. We have to make it clear that whether the vision loss is sudden or a gradual one. And if it's a sudden onset, it cannot be due to cataract. It could be an associated retinal problem or a optic nerve problem. And if the patient is complaining of diplopia, especially if it's a binocular diplopia, we have to rule out the possibilities of fourth nerve and sixth nerve involvement, especially if the patient is a diabetic patient. So in these patients, it is better to defer your surgery for some time till the diplopia settles down, because once you do a cataract surgery in these patients, you might aggravate the symptom of diplopia. You have to take a history of about any trauma, previous eye surgeries or any lasers, and systemic comorbidities has to be noted down. And if the patient is on a glaucoma medication, you just check what the medication the patient is on. And if it's a latanoprost or any bimetaprost, you have to, I think it is preferable to stop it 2 weeks prior to the surgery because of chances of cystoid macular edema in the post-operative. Now, I see ocular history, we all take a proper history. Now, there are certain things which I wanted to discuss with you people. The cardiac history. See, most of the patients who comes to us are on anticoagulants. So we have to know what is the anticoagulant the patient is taking, and you have to note it down. Another thing is like it is preferable in all these cardiac patients, it's preferable to do the surgery under topical anesthesia so that you don't have to stop the anticoagulants, because there's something called a cardiac psychosis. So when you ask the patient to stop the medication, they get into really apprehensive, and then that might cause some other problem. And if the patient is on a pacemaker, you have to avoid cautery in these patients, because the cautery can cause change in the electrical stimulation or the tuning that has been kept in the pacemaker. And if the patient has undergone angioplasty, and if it is less than 1 year of duration, do not stop the anticoagulants. And in these patients, it's preferable to get a cardiac fitness. So something which we miss is the prostate medication, because the patient never complains of prostate problem because they don't correlate that to a eye problem. So we have to elicit a history of prostate medication, and because this will avoid any surprises on the table. And this is something which I wanted to share with you, because of late I have had a patient with the diabetic patient on dialysis. So these patients, what we have to do is we have to check electrolyte levels in these patients. This is something what we miss, because there's something called, most of these patients during dialysis, there is an electrolyte imbalance in these patients. So if the potassium levels are high, what you will end up on the table is an atrial fibrillation. So if you see the electrolytes, you see a potassium levels are high, you have to talk to their nephrologist and ask for a potassium removing dialysis. And this is very helpful, that, and do the surgery or preferably post the surgery the next day of the dialysis, so that your electrolytes are well balanced. In all these dialysis patients, you have to check for the PT, INR, APTT, urea creatinine levels, and you should avoid any oral NSAIDs in these patients. Asthmatic, we know, you ask the patient to bring the inhaler so that they can take a puff just prior to going to the theatre, and if not, arrange for a nebulization, or you can even give a short steroid 1 dose just prior to taking the patient to the theatre. Now, what I do is like I completely do a complete vision refraction for the patients, and this is really important. This will help you in many in decision making about the IOL. And the instructions which I give to the optometrist is that they have to do a complete refraction with the pre-vision and also mention the dominant eye. So that is important, because if you have to decide on a premium lens, a multifocal or mix and match lens, then the dominant eye also should be known to you. And what we do here in our practice is that if the red glow is not good, the optometrist is asked to make a note as DG, that is dull glow, in the EMR. And the patient is informed also that there is a cataract. And muscle balance should be checked. You have to know whether there is any exo or ESO deviation, and because these patients can have an amblyopia associated with it, and which has to, as a surgeon, we should know and explain to the patient. Now, once the vision and refraction is done, the patient is immediately taken for the optical biometry. So, the optical biometry is done in a virgin cornea before instilling any dilating drops. So, this gives us a clear-cut idea about the biometry values and also any pre-op astigmatism that is there in the eye. So, once that is there, the first round of counseling is done by the optometrist. That is, you inform the patient that you have a cataract, and if at all the patient is having an astigmatism, the patient is informed that there is a change in shape of the cornea, which the details of which will be informed to you by the consultant. So the patient, the first round of counseling is done at that level, so that the patient is aware that these things are happening in the eye. And you check the pupil. If the pupil is, does not show any RAPD and the anterior chamber depth is normal, then the optometrist dilate the patient, and then the patient is sent to the consultation. So before the patient enters our consultation room, we are having a very clear picture that the patient is having a DG, that is the dull glow, and there is a pre-operative astigmatism is present, and whichever eye is dominant is, and any comorbidities. So everything comes onto your screen. So before the patient enters your OP, you have a clear picture of all these things. Now onto your slit lamp biomicroscopy, we have to go in a systematic manner. You have to check for any meibomian dysfunction in the lid margins. If at all something you see, then it is better to take a swab for culture and sensitivity and treat the patient for the meibomianitis, like you give hot fermentation, oral antibiotics, any artificial tears which necessary. And if at all any, oral and topical antibiotics, and post the case only once you get a report about the culture and sensitivity. On the cornea and conjunctiva, if there is any pterygium that is there, and if it's an early pterygium, you can leave it. But if the pterygium is advancing onto the cornea, it is better to get the pterygium done first, and then repeat the biometry, and then proceed for the cataract surgery at a later stage, maybe after 1 month, once the pterygium wound has healed completely. If there's any opacity on the cornea, that has to be informed to the patient, so that you have to take a guarded visual prognosis in these patients. Cornea guttata is something which we often miss, and that has to be checked. The endothelium has to be checked for any corneal guttata, pigment dusting, Krukenberg spindle. In that cases, you have to explain to the patient that there is some problem like this. So, post-operative recovery period may be a slightly longer than the normal. And there are chances that you can have a corneal edema, and you might have to use the medications for a longer period of time. And during surgery, you have to use a cohesive viscoelastic in these patients, and also you will definitely have to send the patient for a specular microscope. The anterior chamber depth has to be assessed. This is because if there is a shallow anterior chamber, a pre-op mannitol to be given 20 minutes prior to the surgery will cause the shrinkage of the vitreous and help in reducing the intraocular pressure during surgery. And you have to use the cohesive viscoelastic depending on how shallow the anterior chamber is. If you have on the contrary, very deep anterior chamber, check for the symmetry of the depth on the other side. If it's unilateral deep anterior chamber, ask for any history of any trauma, because There may be an associated injury in the previous history of any trauma, which may be a cause for the increased depth. That means your zonules are weak or there may be a subluxation. So in case, and also if it's symmetrical, you check for the myopia and check for the intraocular lens power so that we get an idea. And in these cases, if the anterior chamber is very deep, you have to reduce your phaco parameters during the surgery. Pupillary dilatation is something we have to assess by ourselves, whether it is poor, moderate, or it's well dilated, and it has to be noted down onto the case sheet. If it is poor or moderate, ask for any, again, prostate medications. And if in case of poor and moderate dilatation, you have to use cohesive viscoelastic. Explain to the patient about the need for pupil expanding devices, iris hooks, because you should not, the patient should not have a surprise on the day of surgery when you ask for extra payment for using extra gadgets on the in the OR. And always you have to have a 3P intraocular lens, 3-piece intraocular lens ready in your armamentarium, just in case you have any problem. You can always use that. Iris, you have to check for any iritis or iridodialysis. And cataract has to be graded properly, but in case of a hard cataract, you have to use a cohesive viscoelastic, and you have to expect a weak zonules in these patients. So it's preferable to do it under peribulbar anesthesia, just in case there is an extension of the surgery. You should not have an uncooperative patient on the table. Posterior polar cataract, again, you have to mention to the patient that there is your cataract is something different from the normal cataract, and there are chances that there might be a PC rent, so there can be any complications. So you have to have extra things that should be ready. In this patient also, you have to have a 3-piece foldable lens ready, just in case you end up in a PC rent. You can always put the lens in the sulcus and use optic capture to prevent further complications. See, dilatation is again important because sometimes we do tend to miss subluxated lens unless you dilate and see the patient. So sometimes if you don't dilate it, what happens is you will be taken up by a surprise on the table that you have a subluxated cataract, and then your surgery entirely changes. So in case of a subluxated cataract, you have to have a white to white measurement because you need to use a CTR in these patients or segment ring. So you need to block the patient. Keep a note on the case sheet that the eye should not be massaged after the block. Fundus examination, a detailed fundus examination should be done. The disc and the macula should be checked. If there is any changes in the macula, that if you feel the macula is like unhealthy, then you should do an OCT to rule out an epiretinal membrane or impending macular hole. And in case of a myopic patient, always check for the periphery for any lattice or any breaks or any holes. In that case, if you identify any of these things, that has to be treated first. You have to do a laser for the retinal holes, and then after 2-3 weeks, you can post the patient for surgery. If you cannot see the fundus, it is always preferred to take a B scan for documentation purpose, because unless if you don't do this, you might end up in a problem later. So specular microscopy, initially I used to do it on a routine basis for all the patients, but now I have confined it to the patients whom I feel the cornea is unhealthy. And in these patients, I do a specular microscopy, and if the cell count is less than 2000 cells, then I explain to the patient about the possibility of a corneal edema in the postoperative period and need for cohesive viscoelastic. OCT, if the vision changes are not corresponding to the lens changes, then it is a must that you have to do an OCT. And if you feel there is a macular lesion like an epiretinal membrane and macular hole or impending macular hole, it is preferable to take an OCT, because you can explain to the patient later that if the vision does not respond to his expectation, this is the reason why your vision has not come back to 6/6 or whatever it is. And all the multifocal lenses, I do an OCT. And in diabetic patients, again, you have to do an OCT because there might be some hidden macular edema which may not be visible on the direct fundoscopy. So in these patients, it is preferable to do a OCT and assess the degree of maculopathy. Again, this is useful for the treatment part of it, because sometimes you might have to do an injection first, intravitreal injection first, followed by 2 weeks or 3 weeks later by the surgery. Or you have to do it simultaneously, or you might have to do the surgery first and then followed by an injection. Shimmers is done on a routine basis in all the patients. Now, my preferred technique of biometry is an optical biometry, because it gives you an additional parameters which will be helpful in making a decision on the best lens for the patient. If that is not possible, it's okay, no problem. You can do an A-scan, but A-scan, the preferred technique is an immersion biometry, because the contact biometry, unless you are doing it on your own, it is so much dependent on the technician who's doing it. So it doesn't give you a small error by the technician can change the IOL power which has to be placed. So we know that A-scan doesn't need anything other than a Prager shell. So the immersion technique is preferred. Now, a short note on a spherical aberration. We know that we have studied the physics of eye, that the parallel rays of light coming from the periphery come to a point focus on the retina. So if the parallel rays are strong enough, it comes to a point focus well in front of the actual point of focus, and that is called a positive spherical aberration. Whereas sometimes the parallel rays may be too weak that it comes to a point focus behind the actual point of focus, and that is called a negative spherical aberration. The net result of is that this is the point focus, and you get a in case of a positive spherical aberration or a negative spherical aberration, the end is a glare and halo. Now, how do you assess the aberrations? See, we all know the cornea has got a positive spherical aberration and the lens has got negative spherical aberration. In young, the positive and the negative spherical aberration together, it is nullified, as a result of which the person does not have a glare or halo. As the cataract develops in the lens, the negative spherical aberration becomes more positive. The net result is the eye becomes more of a positive spherical aberration. So once you remove the cataract, the aberration caused by the lens is gone. But whatever the spherical aberration that is there by the cornea, it remains. So when you are selecting a premium lenses like a multifocal lenses, if the spherical aberration is more, then even when you do the best of the surgery, the patient will not be happy. They might complain of a halo and glare. So that is where your aberrometer comes into use. So this is got an integrated corneal topography and a wavelength aberrometry, and it assesses the corneal spherical aberration. If the spherical aberration is more, you don't advise multifocal lenses in these patients. And again, it also gives you a corneal astigmatism, posterior corneal astigmatism, and also helps in assessing the angle kappa. If the angle kappa is more, you don't advise multifocal lenses in these patients. Now, you have all the measurements and everything ready. Now, how do you manage the expectation of the patient? So, increased chair time is very much important. If you feel the the patient is not competent enough, you have to have your bystander close to the patient when you're explaining the things. You should know what are the hobbies and lifestyles of the patient. And in case you have a astigmatism of more than 1.5 diopters, you have to explain to them about the possibilities of the toric IOLs and fully disclose and discuss with the eye conditions with the patient so that you know what is the visual outcome he can expect. And always tell them that they need to wear glasses for the reading and never give 100% assurity. See, I'm just going to skip this. Now, this is something which I use in my practice. It's a very simple technique to explain the toricity of the cornea. See, I always explain to the patient with the model eye. So I use a smiley which is cut into half and just squeeze the eye and show them that this is the shape of the cornea because of the astigmatism. So that's a very simple technique which will help the patient know their corneal astigmatism. Now you have to document everything what is there in your mind. So I write my case sheet myself. I jot down all the things that has come to my mind and what are the things that has to be kept ready in the theater, so that when I see on the table, I just have to look at my documentation, so I know what was the thing that was going in my mind when I was explaining the details to the patient. And especially, we do take a special concern in multifocal lenses. And extremely anxious patients and claustrophobic patients, it's better to give a sedative prior to the surgery. Now, your patient, you have to explain to the patient everything that is needed and give a non-biased advice about the IOL selection. And always when you give an advice about the IOL selection, you should consider the fellow eye also. And in case this is where the dominant eye comes into the field, you give the best distance correction for the dominant eye. The parameters that comes, you have to think in terms are axial length, keratometry, and the effective lens position. So we know the normal eyes, according to the formula, the 1 millimeter change in the axial length, SRK formula, we know that 1 millimeter change in the axial length can cause a change of about 2.5 diopters in the IOL power. If the eye is of a shorter eye, axial length, then the 2.5, it's more than the 2.5 diopters to change. Even 1 millimeter change in the axial length can cause. Now, if the axial length is more than 26 millimeters, that is, the patient is a myopic eye. So your post-operative goal should be to make the patient more myopic than hyperopic. So in that case, you select an IOL slightly more than the actual power. Whereas in the case of an axial length, if it's less than 22 millimeters, your post-operative aim is to make the patient immetropic or slightly hyperopic. So you select an IOL power slightly lower than the actual power. And Hofer Q is the formula gives the best results in shorter eyes. So keratometry values, that is, if the axial length, the keratometry values are less than 40 diopters, more than 46 diopters, and post-refractive surgeries, you can expect surprises. And in case of an irregular cornea, it's better to take a topography and choose the lowest mean K value. And in all the irregular corneas, it's better to make the patient more myopic. The effective lens position, we all know once the lens is out of the eye, there are a lot of challenges because the anterior chamber depth increases and the IOL which we are going to place is thinner than the normal lens, and there is something called a shrinking wrap effect by the capsular contraction. So the effective lens position, we cannot judge actually which is the effective lens position. So in the shallow anterior chamber, it may be a little anterior, and in the deeper anterior chamber, it will be posterior. Biometry, the second generations are no more in practice. The third and the fourth generation formulas are more widely used. Of this, the SRK T and Holiday is the most widely used formulas. The newer formulas are these. So which formula for which eye? The third and fourth generation formulas are the best. Holiday one fits in most of the eyes. So if you have an axial length of less than 22 millimeter, Hofer Q is better. If it is more than 26 millimeter, SRKT or Vegas can be given. And if it's more than 27 millimeter, it's a modified Holiday formula which has got additional factors that is added on. In case of a post-refractive cornea, you know the K value is very low. So Barrett and Sharma's formula are preferred. So to conclude, your approach to the patient should be in toto. You should consider the systemic comorbidities. The biometry should be accurate. Your selection of IOL should be accurate. And a proper counseling should be done by the surgeon. And you have to maintain the standard protocols. And all these together builds up the confidence in you as a surgeon. So the visual outcome finally then will match to the need and to meet the expectations of the patient. Thank you.
Thank you very much, Dr. Mridula. Can you can stop sharing screen now? It was a very exhaustive and comprehensive presentation on preoperative evaluation, because that is very crucial nowadays. Because whatever good surgery you do, but if your calculations and the dry eye management and all those have not been good, the outcome is not so. Could you please stop sharing? Yeah. So because we are running a little short of our schedule, is Dr. Lubeck there? Can we ask, is there anything additional you will do for premium IOL patients in your practice in the US? We just wanted to know your, could you unmute please? Your one is muted.
Thank you. Good morning, everyone, or evening. I really have little to add. That was a wonderful presentation. I particularly like the eye trace and aberrometry discussion for multifocal lenses, which is critical. To that, I will occasionally put a multifocal in a patient who's had previous refractive surgery, but only if their keratometry is above 41 and they have minimal higher spherical aberration induced. So thank you.
Thank you, Dr. Lubeck. I think we will move on to the next talk. Dr. Mridula, could you please introduce and invite Dr. Matthew Kurian for the next talk, please?
Just give me a second.
Okay, by the time Matthew can please start sharing your screen. Matthew, please unmute also.
Yeah. Okay. Matthew, sir, he doesn't need any introduction as such. He is my mentor. Welcome, sir, for the wonderful session. And he is now the medical superintendent and senior consultant of Chaitanya Eye Hospital. He finished his graduated from the Christian Medical College, Vellore. He finished his MS Ophthalmology from the St. John's Medical College, Bangalore. And he is ex-medical superintendent and cataract consultant of Narayan Nethralaya. He is a wonderful person, very good at heart and very patient. I'm really thankful for the tips you have given me during your training period. Welcome, sir.
Thank you, Mridula. And I would like to thank Minu and the Palakkad Ophthalmology Society for giving me this opportunity to share my thoughts on phaco-dynamics. Phaco-dynamics is basically the partnership of the phaco-surgeon with the phaco machine, which gives a perfect surgical outcome and a happy patient. We all know three forces act on the lens: jackhammer, and after the jackhammer breaks the lens into small pieces, irrigation and aspiration is required to take these materials out. So phacos is the lens and dynamics is the forces that govern the movement of the lens during this process. 5 dynamic surgical components are there during this process that we need to be aware of: the inspiration, aspiration flow rate, vacuum, water coming in either in the form of bottle height or IOP control now with the newer machines, then the ultrasound power. All of them are rate limited by the incision site, and these are all interlinked to each other. To give an overview, sonics is basically the component which looks at the emulsifying power of the ultrasound energy, and the fluidics is the component which deals with the fluid movement in the eye. Machine components and the technology that bring it together comprises phaco-dynamics. Before we start anything with the machine, before the patient even comes into the theater, we need to do what is called as priming and tuning. Priming is our check of the fluidics, where we test for leaks or blockages in the system, and this is critical to get rid of any air in the tubing or the cassette. Why? Because residual air increases the compliance and reduces your system performance. So you might have a fantastic machine, but if there is air in the tubing, it will not work anywhere near your expectations. The tuning of the machine is to check the sonics, and basically at this stage, the machine is synchronizing the frequency of the phaco tip with the piezoelectric crystals in the handpiece. Preoperatively, it is done in BSS, where there is no load, and most machines today have a facility to auto-tune, which is intraoperatively against the load of the nucleus. It is actually rechecking and ensuring that it is delivering the power that you have set. A little bit of history: electrical energy is converted by a transducer into mechanical energy. Magnetostrictive is no longer hardly available. Piezoelectric crystals are the standard of care. 2, 4, and 6 crystals are available. The more the crystals, the better it is, because in case something gets damaged, either in the autoclave process or at any point, you have adequate number of crystals to give a good outcome to the patient. But beyond a certain limit, the number of crystals increases the weight of the handpiece and makes it poor in terms of ergonomics. The frequency is fixed for a machine and ranges from 28,000 hertz to 60,000 hertz. Basically, the number of hertz, for example, most Alcon machines work at 40, the longitudinal ones work at 40,000 kilohertz. That is 40,000 times per second the phaco tip is striking the nucleus. Higher frequency certainly is more efficient in terms of fragmentation, but also generates more heat, and so there is always a trade-off in this equation. The phaco power is varied by altering the axial stroke length, or when it comes to torsional phaco, the amplitude of the rotational angle. Phaco tip is what actually delivers the mechanical energy of the handpiece into the eye and breaks up the nucleus. So you have tips which could be 45, 30 or 15 degrees. 15 or 0 degrees is much more efficient in terms of impaling. 45 degrees is much more efficient in terms of cutting. And the 30 degree tip was a sort of good compromise for both ends. The thicker the tip, the thicker the material of the tip, the less efficient in terms of cutting, but the more efficient in terms of reusability. In terms of the design itself, straight tips, then Kelman tips. Today, I think the balance tip is on the Alcon machine is one of the most efficient tips and my preferred choice, no financial interests there. The mechanism of emulsification, mechanical jackhammer is well established. Cavitation and acoustic were theories that were proposed. I'd like to share this Jami Zacharias video, where basically he took a bit of nucleus, stuck it into a hyperbaric chamber, increased the power, and at a certain point under high magnification, he was able to notice that the cavitation bubbles happened. This was at atmospheric pressure. On increasing the atmospheric pressure to 2 bar, the cavitation bubbles were eliminated. So without cavitation, he measured the amount of impaling at a certain power. And after cancelling the effect of cavitation, he re-measured and was able to demonstrate that there was no loss in the efficiency of the nucleus impaling. So this led him to hypothesize that you need to reduce cavitation, increase the jackhammer effect, because all cavitation did was to produce free radicals which damage the endothelium. Torsional phaco came out subsequently, where you have shearing and was supposed to be more efficient than the traditional jackhammer effect. There was better followability because no repulsion happened, better safety because there was less heat generation, and you were using a lower frequency of rotation. Conventional power settings, the older machines start at 0 and go all the way up to 100. In the newer machines, you can start not at 0, but at 10, 15 or whatever percentage power that you would like to start delivering. The more effective power range is probably between 40 to 80%. When it comes to torsional amplitude, you can go all the way to 100%, but you don't really need it because it's such an efficient technology. You need to modify the power delivery depending on your technique and depending on the step at which you are using that particular power. A rough guide is the picture over here, where for trenching you want to use a formula which is 15 times plus 25% of the nucleus grade. So for example, if it's a very soft grade 1 nucleus, you're using 15 plus 25, that's 40% power. A much harder cataract would require a much higher level of power. Delivering power for a beginner, the quality of foot pedal control may not be so great. So you could go with what is called a panel mode, where you have a preset maximum, And at the beginning of foot position 3 to the end of foot position 3, you are in the same amount of power. As you get more confident with the machine, you could go into a linear or surgeon control mode where you can start position 3 at your preset level of 0 or the threshold and finish it at your preset maximum. As you become more competent in surgery, you want to reduce the amount of power by using various power modulation techniques. You can put off the power for part of the time during the time you are in foot position 3, and that is called as a duty cycle. You can use a 50% duty cycle, in which case half the time you are in position 3, you are actually not delivering power. This is 40% power, and here you can choose the number of bursts in which. So for example, if you have 2 pulses per minute, you will have half time on, half time off, and in 2 cycles. 30 pulse per second means that you have 30 on-off cycles going on during that time. The less amount of chatter and the more continuous form of emulsification happens in the higher pulse per second rates. So this interrupted power looks something like this. It led to 2 concepts. One is burst, where as you enter foot position 3, you go to the preset maximum and the duty cycle is in linear control, whereas the power is fixed, which means that as you go further down in foot position 3, the interval between the on-off cycles becomes lesser and lesser till eventually you're delivering continuous power. In the other form of linear mode, which is called as a pulse, you have a fixed duty cycle, which, let us say if it is 50%, you have half time on-off, and then you deliver the linear foot pedal control for power, which means as you go further down in foot position 3, you're delivering increasingly more power, though the gap between 2 on-off cycles never changes. Further advances in power modulation have happened with microbursts and hyperpulse technologies, where during the on cycle, you are further shaping the delivery of power with an increased maybe punch, with overall lower delivery of power. In hyperpulse, again, a variation of this in the pulse. Next, we go on to the second half of the talk, which is on fluidics or irrigation. The irrigation, we want to balance the aspiration that happens at the phaco tip plus anything that is leaking from the wound. In conventional machines, it was bottle height in the gravity-fed machines, and we were able to manage between 65 to 150, 150 millimeters of bottle height, depending on the machine and what is permitted by the roof of the operation theater. Today, with active fluidics, we can give a much more precise intraocular pressure control inside the eye. In all these situations, the pre-existing assumption is that the pump is at the eye level. Essentially, pumps were 2 different types, peristaltic and vacuum transfer devices. Peristaltic tubes, the aspiration line was pitched between a roller and peristaltic boluses of fluid were drawn from the eye into the aspiration line to equalize the pressure differential. In vacuum transfer devices, the compressed gas passed through a tube in this Venturi model, and this created a pressure differential in the drainage cassette, drawing the fluid from the eye through the aspiration line in an attempt to negate the pressure differential. Conventionally, the original machines, let us say the Universal 2, the vacuum was dependent on port occlusion. It was a slower machine and it was credited with more safety. The vacuum transfer devices like the Venturi, the Star's original machines were more vacuum independent, and they had higher flow rates, and so they were associated with speed. But companies have looked at the other technology and have tried to pull in features from the other technology. So today in the top-end machines, there is very little to choose in terms of differences in how they behave in the eye. The aspiration flow rate is the rate at which the fluid and nucleus particles are removed from the eye when the tip is not occluded, and this is applicable only to the peristaltic machines. This sort of, you can call it as a followability, the speed with which a nucleus fragment comes to the tip. The flow rate can be independently adjusted from the vacuum in the peristaltic machines, but not with the Venturi machines. A good flow, there will be no chatter. The piece will not be flying around like this, repulsed by the tip. And this is more common in the traditional machines with the longitudinal ultrasound, where the fluidics has to work extra hard to bring the tip to the piece. The shearing force used during torsional phaco repels the nucleus fragments much less, and so you have what they like to call in the marketing portion as a magnetic followability. Vacuum is a pressure differential between the atmosphere and within the aspiration tubing. It's a negative suction force created by the pump at the probe tip. You can use it to call it as holdability, and the rise time is the speed at which the system, once it is occluded, reaches the preset maximum vacuum, and it can be made faster or slower on both Venturi as well as peristaltic machines in the more modern machines. Chamber stability is something, the small flickers as it happens, that is basically a surge happening which is not related to a complication. In other situations, it could cause a PC event. What can we do to eliminate or reduce surge? It is to go with the compliance of the tubings. A more compliant tubing tends to collapse and is associated with the likelihood of surge. A low compliant tubing remains rigid even when the vacuum buildup happens. As a surgeon, we can reduce the outflow by using low aspiration rates, decreasing the aspiration port size. We can attempt to increase the inflow by raising the bottle height, but be sure that you don't do it at the expense of turbulence. Machine-specific venting, which is now by fluid mostly, is present almost in every machine. Most of the machines you will get low compliant tubings, so that is not a very major feature anymore. There are some things which are specific to machines. Alcon has got the areas. I will go into it in little detail now. The tips and the sleeves. Active sentry is something where the handpiece is modified and sensors are present in the handpiece to maintain the IOP better, and having the sensor in the eyepiece ensures that the machine is always working at the patient eye level. AMO or Johnson & Johnson now has got the fusion fluidics and the case control. Bausch & Lomb has got cruise control. So improved fluidics happens with the less compliant tubing, which is harder and less likely to collapse. In the older tubings associated with the legacy, the amount of vacuum drop in IOP after vacuum occlusion was higher and recovery was much slower. In the more modern machines, you will find in the Interpret, for example, you will find that the dip is much less and the recovery is much faster. The Turbosonics ABS tip has a small hole in the side of the phaco tip. So when there is free flow of fluid from the anterior chamber, there is no problem. This is not required. But when occlusion happens, there is some of the irrigation fluid is able to negate the vacuum buildup that happens in the aspiration line. The balance tip and the nano sleeve are, since the balance tip has got a uniform gauge, unlike the flared tips that were there in the original Kelmans, the likelihood of lens matter clogging the tip inside is much lesser. The nano sleeve also, with the grooves on the inside of the sleeve, ensures that temperature buildup doesn't happen, and this is probably one of the most efficient combos that is available today. Fusion fluidics on the Johnson & Johnson machine now has got two components. One is the occlusion mode, where you can set independent fluid settings for unoccluded and occluded flow, and case technology, which is something where you can set the amount of vacuum rise, The duration for which the vacuum rise happens after recognizing occlusion, you can then step it down to what is considered as a safer level, and then gradually bring it down to a more normal thing as emulsification continues and chamber collapse doesn't happen. Cruise control by the Boschenlamm was the presence of a small chamber like in a blood transfusion tube, where there's a sieve here which collects the lens fragments, which prevents the nuclear fragments from clogging up any portion of the aspiration line beyond the phaco tip, and prevents the chamber itself, the fluid management system itself, cassette from getting clogged. Essential phaco principles: flow rate is followability, vacuum is holdability, phaco is the ability to remove those fragments. And the differentiation today is not so much on the power side. Tip design, power delivery and modulation, all of them are very advanced. The differentiation today between machines, I think, is in the quality of fluidics, the chamber stability and surge protection that is given. And together you can give a happy patient. The settings that I use for sculpt is a medium bottle height or IOP now on the Centurion system of about 55. The flow rates is around 25-30. Vacuum for sculpting is lower and the power is moderate to high. In the chopping settings, bottle height and IOP doesn't change too much. The flow doesn't change, but I go to a slightly higher vacuum and the power I actually reduce. I'm using more of a flow-based chopping technique. Great thank you to all of you for your patient attendance, as well as to Charlie Kelman, without whose efforts we would not have this technology today. Thank you.
Thank you very much, Dr. Matthew. This was a practical way of presenting phacodermics, which is generally considered as a little dry topic. But these were relevant points which are highlighted regarding a phaco machine to do a good phaco. I don't have to go into any of these details once again. Thank you very much. And because we don't have time to discuss, we'll take it towards the end. And I think I'll move on with the second. Dr. Mridula, can I move on to
Yeah, Minu, I just, before going into your topic, just a short introduction of Minu. I don't think he needs any introduction. He was working there also in Aravind Eye Hospital for some time, and now he is the refractive, cataract and refractive surgery consultant in Chaitanya Eye Hospital. He's presented enough and more number of papers internationally and nationally. And he's recently, I think he's got the best.
So I'll keep it a little short, but around 20 minutes it will take to cover the incision. But are you seeing my screen?
Yes.
Yeah, okay. We'll move on to phaco incision and nuclear techniques or phaco techniques. Thanks to my teachers for teaching me all what I know now. No financial interest in any of the slides or the videos presented. So incision is a clear corneal incision. This is a two-planar incision. The first one, 1/3 to half thickness near clear corneal incision and a straight entry into the chamber. Now you can do it as a three-plane also. The first is the initial groove, then at the point of entry down and enter into the cornea. So here you can see a 0.1 millimeter extension on the inner edges of the incision. This will help for a more free movement of the phaco probe inside the anterior chamber without any leak. At the end of the surgery, I hydrate all my incisions, the sides of the main incision and even the roof of the incision and my paracentesis, and make sure that there is no leak on the table. So especially the sides, and if they are not closed completely, I hydrate the roof also. And after that, I press on the globe from either sides, from just not behind the incision, then it will leak, but anywhere away from the incision to see it is not spontaneously leaking or leaking without, and both the incision. If I have two paracentesis, I'll check all of them. And here pressure from any side does not make the incision leak. That is how I leave all my clear corneal incisions. And here again, if you notice, there is fluid going between the phaco needle and the sleeve. This prevents the heat being transmitted directly onto the incision. But if we tend to move the probe towards the sides like this, it will obstruct the fluid flow through that, and you can transmit energy when you're doing phaco, heat energy directly onto the edges, sides, and if you press down, when you're tilting the tip down, this will pressurize on the posterior lip, and also if you lift up, it will pressurize on the upper lip. All those can cause phaco burns. And here you can make a single planar incision also in phaco in a 2.2 incision. That's also fine. Here support the other side of the globe in a topical case and one plane entry, and this is also fine to do in a phaco. And if here this is a 1.75 millimeter marked keratome from Alcon, no financial interest in that. But then in the second plane, you can stop short when you want to enter, and then it will make sure that you have an exactly 1.75 millimeter internal the length also. See here, the corneal part of the incision, you can notice that is very less, and also it is a wider keratome. It was a diamond blade which was lying somewhere, so I just wanted to use it. But see, it's quite larger for the 2.8 sleeve which you have, and it will keep leaking. Iris will keep coming into the incision. You will have a small pupil. You will have a lot of surge, and so before using any keratome, please make sure it is according to the size of the sleeve which you are using. And this was actually a 4 millimeter blade, which was unnecessarily used for a 2.8 sleeve, which was supposed to be used. So here again in tight incisions, and as I told you, when you're using too much of phaco in occlusion mode especially, and you're tilting it too much, it can heat up the incision and cause, see, this is a white burn which has happened here, a small burn. It may close, but many of these large burns will not let the incision close, and it will cause huge bad astigmatism, and also you will need multiple sutures to close it. Here again a trainee is doing on a scleral tunnel, but see the internal entry is far into the clear cornea. It's almost more than 2 millimeters into the clear cornea, and that again will cause distortion while passing in any instrument. So it's better to remain within 1.75, maximum of 2 millimeters, slightly more. 1.75 millimeters will be ideal, so that you don't get this much. See, the scleral tunnel in beginners can be done so that you can convert at any point of time if you want, or if the lens is rigid, you can extend it on the scleral side and induce least astigmatism. And here again, please note that the globe tilts so much, it shows you that the tip of the keratome is not sharp, and please do not use this kind of blunt keratomes. And just to show you for completion's sake, this is an incision which is made by the femto. And if you find the initial groove correctly with the special instrument which is available, you can easily enter into the pocket which has already been created. And finally, to close any of the incisions which you are at doubt, horizontal suture, pass through the floor and come out through the upper part, and then go in back, and so that your knot can be inside the incision. This closes your incision much better. And even if it is a 2.2 millimeter, even interrupted vertical suture is enough. Radial suture is enough. And if the knot is made outside, please make sure that you rotate it back and it is buried in. Now see the paracentesis, it is a short, small paracentesis, and it has been stretched much because the tight entry of the Simcoe, and it is tilted and rotated, it gets stretched and it sometimes doesn't close. And if it doesn't close on the table for me, I would definitely suture. This is again a case where there is a vitrectomy being planned after this, and so they want very leak-proof incisions. So one suture onto that, and then at the end of it, make sure it doesn't spontaneously leak, or with pressure, it is keeping on leaking right now. So I would put another suture to reinforce this incision and make sure that it doesn't leak on the table. And all these incision sutures can be taken off at a 1 week post-op time. And make sure that you take it off, because if the patient is lost to follow-up, they come after many weeks. These may collect mucus and infection, and they can tend to have corneal infection. So I will move on to the second part of my talk, which is nucleus management tips for success. This is quite a huge topic, so I'll have to go fast to complete it fast. So no financial interest in any of this. We know that we need to make a capsular excess well, not too large, not too small, and then do a very good hydrodissection to make the nucleus mobile. And this is how we do a classic hydrodissection, called cleaving hydrodissection. And then make sure that the nucleus is mobile before you start your surgery. And most of the cases we are used to doing it with the needle, but the rest, most of them learn with the forceps, and we also should learn to do with the forceps. Good high molecular weight viscoelastic inside, so that the chamber doesn't shallow. And the forceps will come in handy when you're doing complicated cases, and also in mature cataracts where you will need forceps to be used. You can use a regular retractor forceps or a microrhexis forceps. And to feel the nucleus, first we need to learn the 4-quadrant technique, which is trenching, dividing, and quadrant emulsification. In Dr. Matthews' talk, we heard all the settings, and so this is how it will take out the epinucleus and the cortex and start with the trench close to the rhexis margin near your incision. This is a temporal incision, and go deeper in the center and come up when you are going towards the periphery, because the nucleus is thicker in the center. And once you are just below the rhexis margin, you can stop short there and make sure you see the brightening of the red glow in the center. That means you're deep enough. People say 2 probe widths, 2 tip width and 3 and all those, but it depends on the tip size which you use. And extend a little bit on the other side. At this point itself, we could crack, but then we can make the other trenches also and then crack. Here the tip should not be occluded at any point of time. Otherwise it will catch the nucleus and you will tend to pull the nucleus. And the direction is towards the center facing, the tip facing down towards the center and coming up towards the periphery. And after that, you can use the same phaco probe at the base of the trench and use a second instrument. I use a chopper because it's long enough so that the walls get supported very well. And or you can use a cross action also. The chopper on one side and the phaco probe on the other side. Both ways it's fine. But the push should happen at the base rather than at the top part of the trench. And once we make sure, rotate it 360 degrees, make sure that it is complete and it cuts through in the central part also. We know that the pieces are fine now. So we will increase the vacuum right now. We don't need too much of vacuum in the trenching stage. And the power can go down slightly, and the trenching power is slightly higher, and it is kept enough so that you don't push the nucleus while trenching. And once the nucleus is brought out of the bag in the pupillary plane, it can be emulsified. Chopping, till if you are not good enough with chopping, we need not chop. You can direct the nucleus towards the phaco probe tip and get the vacuum rise up and emulsify with the vacuum assisted phaco power. And to, as Dr. Matthew was telling, the last piece, we need to reduce the vacuum and be sure that you don't get surge and touch the posterior capsule during last piece emulsification. So then going on to chopping. Why should we chop? It will reduce your phaco power, it will reduce the energy spent, the heating, and it is less strenuous to the zonules, and it is helpful in most of the difficult cases. So ideally we do chopping to make small fragments, and then the pieces are emulsified in the center of the pupil. So we need to have high holding power. So we have to stabilize the nucleus during chopping. And then while removing the fragments, we have to have chamber stability, which is dealt with in detail by Dr. Matthew. It's very crucial to have chamber stability and high followability to keep to get the pieces coming onto your. You have a lot of choppers available in the market, and each individual surgeon will be using a different one. I would show you mine. This is the one which I've been using for the last 10 years at least. Made by Apasami, no financial interest. It is like your little finger, and one side is blunt and the other side is sharp. It comes in different sizes. You can order in different sizes. When 1.25, 1.5, 1.75, even 2 millimeters. And one is blunt and the other one is sharp. And it works for all my cataracts. And we'll go on to specific cases. So here, we'll go on to 2 types of chopping which are essential ones. According to me, there are basically only 2 types of chop. Vertical chop is done for firm to hard cataracts, and using this sharp part of the chopper. The tip is impaled into the nucleus in pulse mode or burst mode, and stop phaco and hold it there. And then the phaco tip is raised up and the chopper tip goes down alongside the phaco needle so that the pressure is balanced, so that the lens is not pushed down while the chopper goes into the nucleus and laterally separates the nucleus. So we'll see it here. The nucleus is embedded with the phaco probe. It's held there without energy, with vacuum, and the chopper goes alongside, and the nucleus is pulled up with the phaco probe and the chopper, and so that the level is maintained. And when you see the cleavage, stop separating too much. Go into the cleavage with your chopper, go down, keep going down, and get more lateral separation so that you get a central nucleus split. So this is how we do vertical chopping. So the next one is horizontal chopping. So here again it is done with the blunt tip chopper. You move on to the equator or the epinucleus endonucleus border, and then impale like we done before, and then there is a horizontal movement of the probe and the chopper towards each other and laterally separate. That's what you see here. And the chopper which we use, as you see, it's the blunt one. It goes to the delineated margin of the nucleus, and with the embedded phaco probe inside, stabilizing the nucleus, it is chopped into different pieces. It can be continued. We'll come on to that later. So there is another thing called stop and chop, where you want to convert from trenching into chopping. So you initially make the trench, like what you do in 4-quadrant technique, and then can make it enough large trench so that you can split the nucleus initially and debulk the center. These are the two things which you will achieve by doing the central trenching and the splitting. This which we are used to in 4-quadrant technique. Do that first. So then you will get space, and then you will get two independent pieces. It can definitely help in rotation and chopping the pieces into multiple smaller quadrants now. So now with the space available, go in either horizontal or vertical, holding the nucleus, and it can be divided. And once that is divided, then change your settings to the segment emulsification and graduate on. And here it's a little harder nucleus. So here you create a larger or a wider trench so that you debulk more of the center, and then do the same thing. So most important thing is to have search which is dealt in very great detail. I'll just pass on the point. See, once the occlusion is released, see the folds which formed on the cornea. This is not a complete collapse, but then the chamber is shallowing suddenly. So this later on can definitely see the buckling of the cornea. So this has to be avoided, which has been described very well by Dr. Matthew in the previous talk. So the concerns while mastering is the right selection, not to take very soft cataracts or very hard cataracts in the beginning, and right chopper selection for the particular technique and the particular case, and maintain purchase and good hold while you're doing the chopping. And you need to use both hands well. To use the second instrument for chopping, you need bimanual dexterity, which we will develop anyway. And the 6 steps to smooth transition. See, a large nucleus or a hard nucleus to start off in the beginning, not a good one. But here again, the selection of the chopping instrument is very crucial, which is fit enough for the type of nucleus. And without immobilizing that nucleus, we will not be able to cut this nucleus into smaller pieces. So identify your firm nucleus, which is good to start off. Identify the good chopping instrument, immobilize the nucleus well, and then start cutting the pieces into smaller pieces. And then when you gain more confidence, you can continue on with harder cataracts and using larger or sharper choppers in safe modes and with good stability. And you can complete chopping in multiple cases. And you can sub-chop these pieces. Large mouths are required for larger pieces, but your smaller tips will effectively emulsify the pieces when you are cut into smaller bits, and your emulsification is happy. And I would thank my son for modeling for this, which he did around 10-15 years back. So we'll come fast to a few types of cataracts to finish off. Soft cataracts, the problem is that it is very difficult to hold the nucleus for chopping. Once you touch the nucleus with power itself, it will get eaten off. And so that is why you cannot hold the nucleus. And after a few attempts, you see that the central nucleus is gone, and you have a bowl there which is not amenable to holding and chopping. So here I would suggest don't chop. See, here is a soft cataract which has been hydrodissected and hydrodelineated. You can take out the epinucleus and the cortex initially so that you identify the nucleus well, and make a trench. In a soft nucleus, you make a narrow trench so that you retain some bit of the central nucleus available, and deep trench, and then split in the center. Once you split, if you can make sure that it is completely split, you can rotate. See, rotating, don't go to the periphery, then you won't be able to rotate. Rotate in the center where you have support with the central harder nucleus available, whatever harder nucleus available, and make sure that you split completely. And once that you split completely, then go with higher vacuum, oppose the nucleus, let the vacuum rise up, pull the piece out, and you can emulsify the whole piece in the pupillary plane, and both pieces can be emulsified like this. And again, another technique which you can use, especially if it's torsional, make sure it's completely rotating soft cataract. Keep your phaco probe embedded, see the vacuum rising up, and continuous slow energy if it is given, and the vacuum is maintained. The nucleus rotates, and the mid periphery of the nucleus, if it is gone, then the whole nucleus lens becomes free inside the bag, and the nucleus comes up easily, and it is completed without any nucleotomy technique at all. Not very easy to do with longitudinal phaco. And another way to do is, if you delineate well and without using power, you can use the phacoprobe to push on the nucleus from one side and pull from the other side with the blunt tip chopper. So there is no energy being used here. You can use a bit of vacuum also to touch on the surface of the lens and continue this push-pull technique, and all the nucleus can be divided. You can see here that energy spent is 0. You have not used energy to go into the nucleus, and after cutting the pieces, it can be emulsified into, and we'll go into firm cataracts where you can use the blunt chopper or the sharp chopper. They are grade 2 to 3 nuclei. But the only point which I want to make here is that after you have divided it into very small pieces like this, we can take off the chopping instrument if you are okay with that. Here the advantage is that the leak through the paracentesis is completely abolished. So if there is no leak, the chamber remains much more firm and you don't get a lot of surge. The rotation of the whole nucleus can be done with the phacoprobe itself, and this is one modification which you can do. And here I am using the sharper chopper. The sharper chopper can be used for vertical chopping, but we should remain in the center. This is a direct chop when you're going directly into the nucleus and holding and making the chop. That also is possible, but any direct chopping, you can see here already a burrow has been made. So I would always do this kind of a small burrow first and then go in for holding the nucleus rather than going in for a direct chop. And then the very hard nucleus, again, the central debulking, that is the point which I want to bring. Debulking the center is very important so that you can finish off the center and emulsify better, but don't take off a big chunk because you need this central nucleus to embed and create a of a vertical and an horizontal movement. This is the slight modification which you can do to complete off this one, and because we are running short of time, I think we'll stop with this. Suprahard cataract will skip. And one more last point, that femto again goes through very hard nucleus also. It doesn't cut the posterior plate, but you can have a circular cylindrical demarcations in the center. It will help in debulking the center. And the cleavages which are already made, you can notice here, the center part has also already been cut. You can separate manually and complete your phaco there. And with this, I'll end this talk.
Thank you, Minu. It was such a wonderful topic and discussion. I think we need to have one-day session with just you alone to get more tips from you. And I think we can go to the next session.
I'm trying to stop sharing 1 second. Yeah, I'll do that. Okay, please do introduce Dr. Jayaprasad, Dr. Mridula, before he goes into the presentation.
Dr. Jayaprasad, he is a founder and chairman of Amardeep Eye Care Centers. And he's the first phaco surgeon of Trivandrum. He's got more than 25 years of experience in phacoemulsification. Over to you, sir, for your presentation.
Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
So there's a little disturbance in the voice. So please keep your mic somewhere close to you.
Yeah, can you hear me now?
Yeah, it's heard very well, but there is some disturbance in the sound.
Even now?
Yeah, now it's fine. Now it's fine.
Fine? Yeah.
Yeah, yeah.
So when I started intraocular lens implantation, phaco and intraocular lens implantation, only 3 lenses were available at that point of time. We had a rigid PMMA lens of 5 millimeter optic diameter. We had a 3-piece lens from Alcon, and then we also had silicone lenses from Allergan, the AMO, which became subsequently Johnson & Johnson. And then over the years, we saw that a lot of developments have come. I have no financial disclosures to make regarding any of the products that is being shown here. I talk about 2-piece acrylic lenses, 3-piece acrylic, non-foldable, the anterior chamber IOL, and iris sutured lenses. Scleral fixated and iris pro lenses have already been discussed in the previous session. So when we'll talk about single piece lenses, remember that single piece lenses can go through any of the injectors, but ideally you should use the correct cartridge and the correct injector, what manufacturer says, and always follow the instruction. Initially at least 20 to 30 cases you do like that, and then you can modify according to whatever you are comfortable with. And if you are running short of cartridges for a single piece lens, you can always use the Alcon B and C cartridge through which any present day single piece IOL will go through. You can use a lacrimal prop, number 1 or number 2, keep it aside for cataracts only, and if you don't have any, you can use it to push the lens. Remember, when you are implanting, there are 2 things to remember. Have a counter from the side, and then ensure that you don't do an wound assisted. Let the endoscope go into the eye, including the bottom V-shaped cut that you see in Hoya injectors. And then you inject the trailing, the leading haptic into the bag, and the trailing haptic you can inject it directly into the bag, or you can dial it in. And please remember, always remove the OD from behind the lens as well as from the anterior chamber, because this was done under continuous irrigation. There was not much of OBD in the anterior chamber. Please remember, in single piece lenses, that those lenses should not be in the sulcus, never be sutured to the iris. It should not be implanted if you are not sure about the integrity of your bag. And if your bag is not, the corneals are not strong enough, you always give additional support. If you have a small PC rent, you can go ahead and implant the lens after doing a vitrectomy if there is vitreous above that PC opening, or if it's in the center, and do a posterior capsular access and proceed. Or if you have always direct the haptic towards an area where you don't have that PC rent, and then slowly dial it in. Alternatively, you can open up in the anterior chamber and gently get the haptics into the bag. At times, you may have to implant high-powered lens like this nano-ophthalmic eye, where somebody has already implanted a phakic IOL, an iris claw lens, I don't know why, and explanted after about 2 years, and then this patient has come back for cataract surgery after 10 years. Now, you can see that there's 360-degree synec, and it's a small eye, 16.5 axial length. So we did a sclerotomy, posterior sclerotomy inferior temporally, and then iris hook, and the nucleus emulsified, capsule is clean, and then a CTR, because 2 surgeries and the zonules were a little dicey. The thick lens, before it is loaded, the tip of the cartridge is cut at small slits are made on the side, so that the tip will open like a beak. This is good in lenses where the power is more than 27, 28, 29 like that, and then extend the wound a little bit, and then you give counter traction. Here, please ensure that the entire slit area goes into the anterior chamber. This is very important, otherwise you'll end up in trouble. And as the lens comes forward, the tip opens, the beak opens, and the lens goes in without any damage to the surface of the IOL. You can also, like what is already available in the Hoya injectors, you can put a V-shaped cut in your regular other injectors using a number 11 blade. If you have a large sonar dialysis, you know that is a simple CTR may not be enough. Sorry about that. A simple CTR may not be enough. Sorry about that. And then you have to put a Sionis ring, anchor it to the sclera, and then you have to implant the lens. This is very important for overall stability of the IOL in the long term. This is a surgery done in 2005. Exfoliation, sonular weakness, not very bad, but definitely sonular weakness. And bimanually you do your capsular access. And once the capsular access is complete, then you hook the capsule. In those days, I always used to use iris hooks to catch the capsule, and then very slow motion phaco, get the entire nucleus out and the cortex, and now you can see the capsule is ready to receive a lens. Now a lens, a single piece lens here is implanted. The one of the implanted after implanting a CTR. This will stabilize the bag. That is what I thought. But then over the years, from world over, we hear that these lenses which have gone into the bag in a pseudo exfoliation patient where the zonules go continuously become weaker and weaker, they usually descend or drop down into the nucleus, and this is not followed these days. in pseudo-exfoliation syndrome. Here we now do use a 3-piece IOL implanted in the sulcus. After cataract surgery, you are putting in a CTR into the bag to stabilize the bag. Then inject OVD under the iris above the capsule, anterior capsule, and then go in with a 3-piece IOL. The tip should always face the left. Always face the left, go under the iris, and as your injection proceeds, the injector should be turned anti-clockwise so that the optic opens at the level of the pupil. Then you dial the trailing haptic into the sulcus. At this point, remember that you go in and wash out all the OVD from behind and in front, and finally you can push the edges down on either side and get an optic capture by the anterior capsule. This enables good stability of the lens in the center of the eye itself. How will we load a 3-piece lens, sensor lens? Now remember that sensor lens is the one that we use, 3-piece sensor lens is the one that we implant in the sulcus because the anterior edge is curved, and I have no financial interest in this lens. Now you can load the lens in 2 ways. You can push it from back, slide it forwards, or just place it on the top and push it down. So this is one way of loading the lens. You put it inside. And here the most important point is the leading haptic has to be going straight forwards. Otherwise it will kink. This is a very important point when you are loading a 3-piece sensor IOL. The leading haptic has to be straight and the trailing haptic has to be looking downwards. And then you can see that it is looking downwards. And then you put it into the unfolder. And here please remember that the trailing haptic has to be sitting on the left side of the injector shelf. And as the piston comes forwards, initially push and then screw the plunger. You'll see that the 2 haptics are coming in the window in that injector where they are seen in line. That tells you that this lens is ready for implantation. The advantages, the major advantages of a 3-piece IOL is the fact that it can go into the bag or into the sulcus, can be sutured to the iris or to the sclera, can be glued to the sclera, can be sutured to the iris if there is a delayed subluxation, and can act as a CTR if there is a localized, for example, in following trauma, if there is a localized zonular dialysis. These 3-piece lenses are also excellent lenses for secondary IOL implantation. Here, 30 years back, cataract needling was done for this congenital cataract patient. So blunt and sharp dissection, releasing the posterior synecdoche, and then using triamcinolone, you go in and do a good vitrectomy, ensure that all vitreous goes behind that whatever is remaining of the capsule. And then you go in with a 3-piece lens, always to the left, go into the sulcus, turn your hand anti-clockwise, the optic to go flat at the level of the pupil, and then inject more OVD and then dial it into the sulcus. This is very important. At this point, you can constrict the pupil eyelid, you can put a dilute pilocarpine, and then go in and put an iridectomy. Iridectomy is very crucial. This is a small eye. And then you can also use 3-piece lenses when you have a large PC rand and then half of the nucleus there remaining there to be removed. You can get it out with a dispersive OVD. I use Orocort Plus. I know financial interest. Do a vitrectomy. And then you go into the 3-piece IOL to be injected below the nucleus. Remember that if it's a hard nucleus, please do not try all this. You just enlarge incision and take it out as in an SICS. But here it is possible because it is very soft and you use a lot of dispersive OVD over the nucleus. And then you can go in and do your emulsification, remove it, use your vitrectomy again, ensure that there is no vitreous, and take out all the residual cortex as well. This is one iris sutured IOL is one thing that is not very popular. I love doing this. It also takes time, a little more than your iris claw lenses. But here what we do is, this is one patient referred to me for refixation of the IOL, a pseudo-exfoliation patient. What we do is that same IOL we have taken, pushed it up, it got a pupil recapture. And then we use 10-0, 9-0 proline and suture the haptic to the iris. We use a zipser knot to tie this. There are multiple types of knots and different ways of tying it. Each surgeon can decide what he or she is most comfortable with. So both the sides you suture, and once that suture is in place and it's very strong, then you can go behind and cut off whatever residual capsule is there and make the central area clear and push back the optic to its normal position and then do an iridectomy. My pupil looks little oval. That is why, because I have put it too tight. Most of the people put it very loose, but I think that will create a lot of UGH syndrome. And at times when you don't have your pupil, to catch the optic during an iris fixation, iris suturing, I always put a pars plana to pars plana 90 suture, over which I'll implant the lens and then fix the IOL to the iris and then take off this suture. That I call it a bridge suture. And no presentation on IOL is complete without talking about ACIOL. It has been shown over time that meta-analysis have shown that the long-term outcome of ACIOL is as good as scleral fixated, iris fixated, and iris flow lenses. Only thing is, you should not blame the lens for what you have done. Always remember, close the eye and do a good proper anterior vitrectomy. Once that vitrectomy is over, then you can constrict the pupil. Fill the anterior chamber with OVD, but do not overfill. Use the correct power, the correct side with the trailing haptic tip towards the left, and the correct size of horizontal Y to Y +1. And this is the correct side. And then you introduce it into the anterior chamber. Some people use glide. You can go over the iris. Try not to catch the iris on the way as you implant. And then if you have caught, you can go in through the side port after filling with further OVD and catch the haptic towards the center 2-3 times. This is a very important step so that the pupil becomes nice and beautiful. And please don't leave the eye without doing at least 2 iridectomies. This is very crucial. Now, let us look at some of the problem situations. The haptic at times can get stuck like this if your loading is not proper. So then you can cut it across. Ideal to use it number 11 regular blade to cut this because this plastic is quite hard. You can take it out, release it from your injector tip, and now you see that the lens is actually upside down. And when the lens is upside down, see these lenses, I don't think there's much of a problem in leaving it behind like that. There's not much of a problem. Otherwise, you can turn it upside down, get it into its normal side up. But always try to use bimanually. I have done it with a single hand. And then at times what happens when you inject, the haptic is not only caught, but it's also cut. So amputated IOL should not be left behind. Go in and cut or explant in whichever way you are comfortable with. There are umpteen number of techniques described over the years. I love doing this. Support the lens, and then cut across. But always remember, as you do this procedure, extend the wound a little more before you take it out so that you leave the eye with least damage to the endothelium as well as to the posterior capsule. And then you can implant a new lens. And at times you may land up with this sort of a small chip in the edge of the optic. That is very rare, but it does happen. And please remember, if the central 4 millimeters of the optic is clean and not damaged, you can leave it alone. The peripheral chip can be dialed so that it goes under the upper lid and under the anterior capsular rim. And then at times, this is a sensor lens, which sensor injector and the sensor cartridge injecting is very tough. I should have come out at this stage. I did not come out at this stage. This is the only one that has happened. Then it went and hit the posterior capsule, vitreous loss, vitreous came up. So I did a vitrectomy and then got a reverse optic capture of this lens. Always remember, when you are using a single piece IOL, before you inject the lens, go into the eye, pull back the piston and see that the haptic is not caught behind that sponge, in that silicone sponge, before you go into the eye. And always inspect the injector, because you'll see that at times what is supposed to be looking towards north is looking towards west or east, and hence these should be discarded. And then of course at times you should also look at the lens before implanting. This is a toric lens where it's a late cut lens where the polishing is not good enough. I thought initially I had mistaken the lens. It is a regular toric lens, but it looks like a multifocal lens. I had explanted one lens. And to avoid all these mishaps, as this article came this time in IJO from Pondicherry Aravind Hospital, where the assistant also uses a small magnifier. You can take your magnifier, stand magnifier from your LBA clinic and give it to your assistant, who can see the lens and the injector tips better so that you will have less of these mishaps. And then when you are in your OT, please remember you should have plan A2. Plan A2 is you have a twin lens of the lens that you are implanting so that at no point of time you are under stress. If the lens falls down, it breaks, whatever happens, you are not under any sort of stress. And then you also have a series of sensor 3 pieces. I have no financial disclosures regarding sensor, but I love these lenses. And you keep a battery of lens. Please do not buy these lenses. Ask them to keep an inventory and delete every month depending upon how much you use. You also have a backup of anti-chamber IOLs as well as all the accessories you need in case of a difficult situation. And delayed complications have to be said before I complete, because last couple of years I had a lot of patients referred with opaque IOLs. It has already been described in the literature over several years. It's calcium phosphate that is coming in and depositing inside. Unlike in Alcon single piece, Alcon Acrysop material where you have glistening, here you have calcium phosphate inside, and the vision is usually dropped down to 6/9 to 6/60. If the patient has, in its early stages, if the patient has no visual symptom, you have just found out in your examination, please don't do any capsulotomy because it will aggravate the opacification and subsequent removal will be difficult. Most of the patients will just say that their vision is gray or foggy vision. If the patient doesn't have symptoms, please leave it alone. Otherwise, you can cut it like any other lenses. These hydrophilic lenses can be cut very easily. You can explant it. And please remember that these haptics will not be stuck. Unlike hydrophobic lenses, they will be it is very easy to remove these lenses. And once these lenses are removed, depending upon whether you have got a bag or not, you can implant a single piece or 3-piece lens. Here I have implanted a 3-piece lens. And finally, since it is already time, I have only one slide on new IOLs on the block, which I am interested in. The iHands, I think it's from Bausch & Lomb, Vivity from Alcon, and Atta Comfort is from a small company in India, which has made these lenses from hybrid material. Hybrid material is a combination of hydrophilic with a small component, hydrophobic with a small component of hydrophilic, so that there is nil glistening. Glistening is the main issue with hydrophobic lenses. These lenses give excellent distant and intermediate vision, but if you can mix and match and do a mono vision with these lenses, I think you may get wonderful results. I don't implant much of multifocal lenses, multifocal and trifocal lenses. With that, let me conclude, Minu. Thank you very much for this opportunity. I'm talking on a stage after a long time. Thank you so much.
Thank you, sir. And iHands is from Johnson & Johnson, our previous AMO people. And a wonderful presentation. You should not be off stage for this long time. You should keep coming and talking. We'll keep on inviting you for this one, for such fantastic presentations like this. If you could stop sharing the screen.
Yeah, stop.
Next, I think we'll go on to the much awaited final presentation. The last but the best to come would be by our keynote speaker, Dr. Lubeck from Chicago. Let me give a short introduction. He has been a great friend for a long time. We have been doing courses together for many years now. Dr. Lubeck is a cataract and corneal and refractive surgeon who has practiced in Chicago for 30 years. He completed his medical training in Northwestern University and then his ophthalmology residency in the University of Illinois Pioneer Infirmary, Chicago, Illinois. A fellowship in corneal surgery was served at Flinders Medical Center, Adelaide, Australia. He is an assistant clinical professor of ophthalmology in the University of Illinois Eye and Ear Infirmary, Chicago. Dr. Lubeck is compelled by the methodology and psychology of surgical learning and practice development. His primary focus is to make current surgical principles, techniques, and instrumentation accessible to physicians at all levels of experience. Curricula that he has developed have been integrated into surgical teaching programs at several countries. With this short introduction, which is very short for his biodata, which you can read for multiple pages, I would invite Dr. Lubeck for the next 25 minutes to go on with his keynote address of FACO in difficult situations. Over to Dr. Lubeck, please.
Good evening, Minu, Dr. Rohan, and the Palakat Society. Thank you very much for having me today.
You can start share screen. Yeah.
So I'm pleased that this session is now, it's really one big talk. Every talk that's preceded will be referenced in this and is critical or key to really understanding how we do phaco in difficult situations. So I'd like to talk about surgical strategies, tips, and pearls for the management of complex cataracts. I practice in Chicago. I'd like to thank all of my teachers, including those from Aravind Eye Hospital, who've made me comfortable and capable handling complex and challenging surgeries. So the short list today, I'd like to talk about small pupils, polar cataract, extreme axial length, both short and long, and poor zonular support. I believe that successful management of difficult cataracts requires minimization of the stress to one or more of the intraocular structures and minimization of stress to us, the surgeon. So let me talk about that first. I understand that our audience today is of varying degrees of training and skill. So I think it's important that we maximize the ergonomics of microsurgery, that we develop really capable bimanual dexterity. We have a deep understanding of fluidics, and we have a difficult case toolkit always available to us. So during microsurgery, maximum control is achieved when the surgeon sits with a straight back and neck, thighs parallel to the floor, and elbows at 90 degrees with upper arms against the side of the body. To achieve this, set up theater in the following order. Stool height first to get your leg position correct, then the microscope height so that your neck and back are straight, and then finally the patient eye height. So again, to note is that when I'm in my final position with my feet on the pedals, my thighs are parallel to the floor or close. Then I bring the scope in so that my neck and back are straight, and I'm looking forward, not down into the microscope. And then my arms lock at the side, elbows against my waist, and then my arms forward, which gives the maximum stability. So for bimanual dexterity, it's critical for difficult cataract surgery. And to achieve it, we need to train our non-dominant hands. This is what I did and what I still teach, which is to, if you know how to learn, if you know how to use chopsticks with your right hand, then learn how to use them with your left. If you don't, then it is, I think, the best phaco training skill that you can have. And of course, it's easy to do and it's fun, and you can do it with your family. And I hope I make it look easy. It is not when you start using your non-dominant hand. So once you have trained, or at least begun to train, then there's the intent to use your second non-dominant hand. And then finally, you just have to do it. You have to instruct yourself to make use of your non-dominant hand. In this case, this was a very thick polar cataract that went through the posterior capsule, and I wanted to be so careful about not manipulating the nucleus that I made a second keratome incision, and then did left-handed phaco to remove the opposite hemiquadrant of nucleus. And then finally, the fluidics discussed earlier. Thank you, Dr. Matthew, because I've always been an advocate for understanding fluidics well. It is difficult to teach. You did a wonderful job. Specific to today, we need to talk about and understand turbulence, which is the creation of excessive intraocular fluid currents inside the eye, overpressurization and underpressurization, and finally, equalization, which is allowing the IOP in the anterior chamber to reduce before removing the phaco or the INA handpiece from the anterior chamber. The difficult case toolkit, I think that most of us have these. We've talked about them. I think the only things that were not mentioned previously were a pars plana trocar. I think that we should all be capable of doing a pars plana vitrectomy for difficult cases, especially the anophthalmic eyes. And then femto laser, I don't know if you're using Zepto. I'm not, but it probably has a place in complex cases, and then finally MyLoop, also I don't use, but may be of interest to some. For my difficult procedures, I have a specific program in my machine. You'll see it's labeled as such, a lens iris unstable. The basic parameter differences are lower IOP, a lower vacuum and flow rate with a ramped position 2, an IOP ramp of 2 to 3, and then irrigation factor, which adjusts for fluid leakage or compensates for leakage. So small pupils. Many small pupils that won't dilate are due to some degree of sphincter fibrosis. So sugarcane injected or epinephrine lidocaine, release synechiae, peel the pupillary sphincter membrane if present. I'll show you an example of that. Pupil stretch with 2 Kugeln hooks, and then finally pupil expanders, Malyugins, B-Hex, I-rings. I use very few of the devices, but again, they need to be in our capabilities. So this is from Dr. R.C. Paul, our colleague in Kolkata,
and along the pupillary margin, this is being peeled off in 360 degree. Once the membrane is released, now the pupillary size is 6. This is the post-op.
So I've found that if you look closely, many of our small non-dilating pupils do have a fibrotic membrane around their ring. You can use a microforceps or Utrada to grasp that fibrotic ring and peel it off the pupil, and then it will expand normally. Here's my normal pupil stretch technique, which is dispersive viscoelastic in the anterior chamber, 2 Kugeln hooks, 1 stretch in opposite directions, all you need, creating microsphincter tears along pupillary margin, additional OVD, which will expand the pupil to a workable range. I'll skip the expander. Now, the second type of small pupil are the myogenic pupils that during procedures will become smaller, including IFUS. These are caused or exacerbated by fluid turbulence in the anterior chamber and any direct contact of instruments with the iris. So myogenic small pupil cases can be successfully managed by minimizing turbulence in the anterior chamber with advanced fluidics and a conscientious nucleus manipulation. So this is a case which demonstrates everything. So stripping of synechiae to begin with. So the fibrotic component is released, and then the pupil stretch is used to create microsphincter tears. If you can enlarge your pupil to capsulotomy size, I believe you can successfully complete these cases without an expansion device. So care must be taken at this point that minimal turbulence is created. Here during phaco, again, note the parameters. They've been decreased IOP, AFR, and vacuum. And using an understanding of the length of the second instrument, keeping the phaco tip in the center of the eye, but then using the second instrument going sub-iris in the capsule and completing phacoemulsification and irrigation aspiration through a relatively small pupil without having to put in an expansion device. So to do these things, very snug incisions, no fluid leakage, dispersive viscoelastic, an IOP of 28 to 40, decreased flow rate, decreased vacuum, and a phaco tip that's well centered. We have all mentioned polar cataracts. We, in removing them, attempt to reduce stress to the capsular bag and prevent PCR. Flax, if available, is wonderful. In that situation, use a cylinder pattern only and ablation well above the polar opacity. Hydrodelineation only, no hydrodissection. Do not rotate the nucleus. Debulk the anterior, central, and peripheral nucleus and release peripheral cortex before removing the posterior nucleus and cortex. avoid sudden pressurization of the anterior chamber, lower the IOP, have a high IOP ramp on your machine if it's a Centurion, part of the Infinity. And if the posterior capsule is open, do the anterior vitrectomy, place a 3-piece IOL on the sulcus with optic capture. So this is a polar cataract done with flax. As you see, the polar opacity, the ablation is above it. Then a cylinder pattern is created, which allows the anterior mid-nucleus to be debulked easily with minimal manipulation of the nucleus. With advanced fluidics, it's feasible and actually not difficult to operate at an IOP in the 20s, which we would have never thought possible previously. But I now do it routinely on these difficult cases, and maintaining a low IOP will minimize the chance of sudden overpressurization and turbulence. So again, what's happened here is that the peripheral nucleus, peripheral nucleus was debulked before the posterior nucleus was removed. In this case, this was the rest of that left-handed or bimanual phaco I showed. There was a large PC rent. The vitrectomy was done. 3-piece lens placed in the sulcus with reverse optic capture, giving up, I think, a lovely and a very satisfactory result. So for the next group of unstable lens iris diaphragm patients, these include both the shallow AC short with increased vitreous pressurized and the long status post vitrectomy or trabeculectomy eyes. In both groups, we're attempting to reduce stress to the lens iris diaphragm, minimize sudden pressurization, depressurization, prevent or break pupillary block that will occur in these situations, and then mitigate the patient pain that will occur if they're being done under topical anesthesia. So with the short eyes, so those that have either a shallow AC and or increased vitreous pressure, as fluid or viscoelastic is put in the anterior chamber, the iris is pushed back against the capsule, causing reverse pupillary block. This can lead to sudden movement of fluid behind the iris, shallowing the anterior chamber and iris prolapse. So essentially, the point of this diagram is to tell us to not overfill our anterior chambers with viscoelastic and short eyes, even though it's what intuitively we think we should be doing. If you overpressurize, then you're going to cause this to happen. A real practical example of this was during hydrodissection. I did not release pressure appropriately from the main incision and the iris prolapse. So with these patients, I recommend using IV mannitol pre-op, 12.5 grams, given intravenously over the 10 to 15 minutes before the procedure. The capsular X's do not overfill the anterior chamber with viscoelastic. Use a soft shell cohesive bubble in the center of the dispersive viscoelastic. Use either a micro-X's forceps or a cystotome through a 1 millimeter incision, and if flax is available, it is very beneficial. As a general compliment, you as a group of surgeons are much better at doing capsulotomies than surgeons in the U.S. And so I've learned most of my capsulotomy techniques for these cases from you. During hydrodissection, inject BSS slowly. press the cannula against the back lip of the incision to hold back the iris and create a small gape in front to release the excess pressure. And then finally depressurize the lens in the anterior chamber before removing the cannula from the eye. So here, the cannula is being pushed slightly posteriorly. It's in the middle of the incision. It keeps the iris from prolapsing and allows viscoelastic to escape over the cannula, ending overpressurization. For the phacoemulsification in INA, once again, fluidically, we want a snug sleeve to incision size. Place a small amount of subincisional viscoelastic prior to entry. Enter the anterior chamber in foot position 0 with these cases. Lower the IOP to 28 to 40. Have a high IOP ramp. Protect the posterior capsule with second instrument. And soon, or now or soon, we'll be able to hybrid polymer phacotip, which I will use in high-risk cases. For INA, again, a polymer or silicone-tipped eye is helpful. And then I've put in green, I think, my most important single tip, which is go to foot position 0 and allow the pressure to be equilibrate before removing the phaco or the INA tip from the eye. So as you're finishing phacoemulsification, irrigation, aspiration, keep the tip in the eye, go to foot position 0, and then remove the tip after a few seconds. So here's using a spatula as posterior capsular protection. I'm in foot position 3. I finish emulsification. I go into foot position 0 there, and then I wait, and then I withdraw. You see no change in chamber stability when I do that. And then finally, for the uncontrollable anterior chamber, or the anterior chamber which is just too shallow to manipulate surgically, my preference is a pars plana vitrectomy. Also, of course, a pars plana tap works, but I believe that this is the preferred technique. So you place a single 23 gauge trocar and then do a small core vitrectomy, which will release vitreous pressure deep in the anterior chamber and allow a safer procedure. So for the opposite unstable iris lens diaphragm eye, the long or status post vitrectomy eyes, as fluid or viscoelastic is put in the anterior chamber, the iris is pushed against the capsule, causing reverse pupillary block. This can lead to sudden posterior movement of the lens iris diaphragm with deep in the anterior chamber, sudden widening of the pupil, and sudden pain and patient movement if under topical anesthesia. So it's a phenomenon we're all familiar with. You see the pupil widen, the patient will wince, and we don't want to pull out, but we often do. With these cases, snug sleeve to incision size, enter the anterior chamber in foot position 1 so that you build the fluid flow more evenly. Have a lower IOP, an IOP ramp of 2 to 3, which is the speed with which the IOP builds once you're in the eye. Have a spatula lift the iris as the phaco or IOA tip or the INA tip is placed in the eye to prevent reverse pupillary block, and if necessary, place 1 to 2 iris retractors if the spatula lift is not feasible. The spatula is placed underneath the iris edge, foot position 1 for entry, and you see that there is no movement of the iris or lens posteriorly. And once you've released it, you do not need to hold the spatula there. Same thing for the INA. Stable chamber, no movement of lens iris diaphragm. And you can use the INA tip to release or lift the iris off the capsule and prevent reverse pupillary block. Finally, the group of patients which I think I enjoy the most because they present the most intellectual and surgical challenge are those with poor zonular support, pseudoexfoliation, trauma or ectopia lentis. Our goal as surgeons is to attempt to reduce the stress of the capsule and zonules, minimize stretching and tearing of the existing zonules, maintain capsular integrity, and if needed, secure the capsule intraoperatively and then permanently to to successfully remove cataract and place a lens. The capsule and zonules can be weakened by overpressurization of the anterior chamber, tension on the capsule during capsulorhexis, manipulation of the nucleus during phaco emulsification, manipulation of the cortex during INA, and insertion and manipulation of both lenses and the capsular support devices. For the capsulorhexis, I recommend filling the anterior chamber with a dispersive viscoelastic to stabilize the lens and act as a vitreous dam. Support the capsulorhexis edge with microforcep, Kuglen hook, or capsule support hooks if there's inadequate zonular support to do a tearing rhexis. So if you start your rhexis and the capsule is so flaccid that you cannot tear without significantly pulling on the zonules, then you can put a second instrument in the eye and hold or grasp or support the edge of the capsulorhexis as you finish moving around the CCC. Start the capsulorhexis 180 degrees away from the area of weakest zonular support and then tear toward the weaker area. Make a slightly larger opening of about 6 millimeters to facilitate nucleus removal, or if a capsular support segment, if a suture capsular support segment may be required. And finally, flax is the most valuable tool for doing capsulorhexis in the absence of adequate zonular support. Phaco emulsification, again, dispersive viscoelastic. Place up to 4 capsular hooks after capsulorhexis to stabilize the capsule in areas of zonular insufficiency. Use higher energy and emulsify the nucleus segments above the capsular plane. Do not rotate and manipulate the nucleus, do not rotate or manipulate the nucleus as little as possible. Use chopping techniques to draw opposing forces toward the center of the lens, as Minu has demonstrated beautifully. Use a nucleus removal pattern that minimizes the X, Y, and Z axis manipulation. And again, flax to facilitate efficiency of nucleus removal. So this is a demonstration of a technique that requires no nucleus rotation. You create a V channel. So 2 grooves and that go across almost the entire lens, and then chopping to separate that V-shaped segment. You then remove that segment, and then you pull the 2 outer segments into the middle, thereby minimizing stress to the zonules and hopefully maintaining what little zonular support already exists. For capsular support, place up to 4 capsular hooks after the capsulorhexis to stabilize in areas of zonular insufficiency. If there's less than 180 degrees of zonular deficiency with an intact capsular bag, place a 10 to 12 millimeter capsular tension ring. For more than 180 degrees of zonular deficiency with an intact capsular bag, place a 10 to 12 millimeter CTR and 1 to 2 sew-in segments or a sew-in capsular tension ring using 9-O-proline, 10-O-proline, or 8-O-Gore-Tex through the sclera to either a Hoffman pocket or the subconjunctival space. We can talk about this in more detail, but I place the sew-in segments and I tighten them gently, but I don't finalize the knot until after the lens is placed in the bag. The video I'm going to show you, I did that differently, but I've learned over time that if you tie those capsular support segments or sew-in IOLs too much and too early, you end up stretching the capsulorhexis and possibly tearing it. If the capsular bag does tear, then the capsular tension ring must be removed. So I'm going to finish with a case that I think exemplifies all of the topics discussed today in our session and the concerns I brought. Don't tell me it's not going to run. Excuse me. Okay, let me do this. because I really want to show this. Okay. Is my other screen showing now? All right. I hope you can see this. This is
I think it's your video has not come up. It's the PPT slide which is showing up, I think.
All right.
So you may have to
stop share.
Share again. Yeah.
How about now? Minu, is it?
Yeah, it's playing. Yeah, it was just started playing. Correct. Good.
So, anyway, this is an ectopia lentis patient. He's in his early 40s, and so this is one which I did use flax so that I could achieve a capsulotomy in the approximate anatomic center of the lens. It's a chop pattern for the nucleus. The interesting thing about the capsule, it had a very sort of rubbery consistency, which was good. It was a strong capsule, as you see by at least the capsular tags. So filled with dispersive viscoelastic. Capsular support hooks to bring the lens to an anatomic center and support it during nucleus removal.
I think it's not. Is it playing?
It is
the
for me.
video is not playing.
It's not playing. It's actually stopped in the beginning itself, I think.
Okay, that's very unfortunate.
It had actually started to play. So I think if you share once more with just the video.
Okay, now do you see it?
Yeah, it's gone little forward now. You can start from the beginning. It's almost halfway through.
All right, let me take it back to here, post flax.
Yeah.
And so incisions are made for the capsule hooks, dispersive viscoelastic in the anterior chamber. I visco dissect underneath the capsule prior to placement of the hook to create space. So dispersive viscoelastic under the capsular edge. The lens centered nicely, and it was not a particularly dense lens, so it was more of an aspiration, but you do see that the capsule stays the peripheral capsule stays relatively stable, and that the remainder of the lens is aspirated out. So with all of these surgeries, the completion of each step is a bonus. So having now reached this point, I was already very satisfied with the progress, not knowing if the rest would be achievable. So now a cohesive viscoelastic to fill the capsular bag. Because of the small lens size, I started with a 10 millimeter CTR, and once that was successfully placed, and knowing that the capsule was fairly elastic in consistency, I then placed an 11 to expand it to what I hoped would be a fairly normal size. Remove the two capsular hooks in the area where the sew-in segments are going to be placed. I did these subconjunctivally, so a peritomies were made. The two sew-in segments were passed. I do these with long needle, ninoproline long needle, trans AC, and then so I'm going to jump to the happy ending and the conclusion of this procedure, which is with well-centered, in the bag, single piece IOL, and a very satisfying procedure. So, to finish, and to end this, I would like to no, not going to do it. Anyway, so with difficult cataract situations, understand the vulnerabilities that make the situation difficult, attempt to reduce, eliminate stresses to the eye and the surgeon, utilize our technology and ingenuity to achieve successful results, and enjoy our careers as surgeons. Thank you very much. Please don't hesitate to contact me if you ever will be in Chicago or if you have questions about what we've talked about today. Thank you, Minu.
Thank you very much, Dr. Lubeck. When I suggested take up few difficult situations, I had given him 5-6 of all these together, and I was wondering how he is going to complete all this in this 25 minutes. And I should tell that all the practical points which a surgeon should know in these kind of difficult situations have been touched upon and clearly mentioned, and all of us who have been dealing with these kind of difficult situations know that these are the crucial steps which should make the difference in the outcome of a perfect case in such kind of difficult situations. Thank you very much for going in detail and taking your time off and accepting very readily when I invited you for this meeting, and taking your time off and preparing this one on a lengthy note. And thank you very much. And with this, I think we don't have time for I have asked for a 10-minute extension to Rohan, and he has gracefully accepted that. We have exactly finished in that extended 10 minutes time. I think I'll conclude this session. There's not much of time for discussion. And I would thank all my moderator and all the speakers for this excellent session. This was a fantastically crisply made talks by everyone, and giving out very practical tips for all surgeons at different levels of training and experience and skills. Thank you very much, PSOS, Dr. Rohan, Prashant for the introduction, and KSOS for this opportunity. So Dr. Lubeck, once again, thank you very much for your time.
And thanks to all of you. Be well and have a good week.
Yes. Thank you. Over to Dr. Rohan, please.
Thank you.
Thank you, Palaka.
At the outset, it's been a big experience for us in PSOS to coordinate the Star Wars and conduct the CME. This happens to be one of the longest webinars in ONDEC conducted by KSOS. We are gratified with support and encouragement from TNOA, all the high-profile dignitaries, our parent association, KSOS president, secretary, scientific committee, all were behind this support today. At least these type of webinars at least throw some positive energy to all of us in this most difficult COVID pandemic. I thank chairman, moderators, panelists of all sessions for doing this job to the fullest and keeping up the time. I thank Dr. David Lubeck for accepting our invitation and being the part of this webinar. I thank each one of you and to all my PSOS members for constant support and encouragement for this marathon webinar. I also thank Intot and the full technical team who have done a wonderful job to keep the things going. We had a slight hiccup in between, but they are rectified very soon, very fast, and we could finish it in time. Our president, Dr. Rajawal sir, will say a few words. Sir, over to you, sir.
Am I audible?
Yes, sir. Yes, sir. Yes, sir. Very much.
Very good evening to all of you. The annual CME of Palakkad Society of Ophthalmic Surgeons has been a marathon one from morning to night, covering all aspects of ophthalmology. All sessions went on exactly on time. All chairmen, panelists, speakers, and excellent presentations. All participants must have enjoyed the program and gained some good take-home messages. Group practice has been a novel idea and definitely this will open new avenues for upcoming ophthalmologists. PSOS places on record our deep gratitude to TNOA, KSOS, chairman, panelists, speakers, and participants for making Monsoon Spice memorable. Congrats to Dr. Rohan, the architect of Monsoon Spice. This webinar would not have been possible without the help of Endor Pharmaceuticals, especially Mr. Raman of Endor, who coordinated the program well. Thanks to everyone who made Monsoon Spice excellent. It's a great honor and privilege to wish all the best to each and everyone who have been part of Monsoon Spice. Thank you very much.
Thank you, and happy Onam to all.
Thank you.
Happy Onam, sir. Thank you very much. Bye.
Thank you so much. Rahul, can we go offline now?
Thank you, Mino.
Yeah.
Thank you. Thank you.
Thanks.
Thank you, sir. Thank you.
It was nice listening to you as usual.
Thank you. Lovely. I'm very impressed by the entire program. It was great. And our session, you